السلام عليكم ورحمة الله وبركاته. النهاردة يسعدنا إن احنا نقدم ويبينار على fractures of the neck of the femur in young adults. والسيمينار ده تحت مظلة Egyptian Pelvis and Hip Society. ويشرفنا النهاردة فقرتي عزيزة علينا جدا الأستاذ الدكتور أيمن عبيد كلية الطب المنوفية، الأستاذ الدكتور طارق الخضراوي كلية الطب اسكندرية، وأخويا الدكتور الأستاذ الدكتور عبد الله حماد من اسكندرية، ومعانا الدكتور أحمد البخوري الطير المهاجر من جامعة اسكندرية، وهو دلوقتي في بليموث في إنجلترا. الويبينار ان شاء الله يعني هيبقى حاجه لطيفه ومينلي cases for discussion. انا هقدم introduction بسيطه عن الموضوع واهميته، the importance of such a very unsolved fracture, and Professor Abdullah Hamad will talk about ways of management, and then Professor Ayman Abed will present his cases. Professor Al-Khadrawi will moderate the discussion about these cases, and then at the end of the meeting, Mr. Al-Bakuri will present his cases, and my dear friend Professor Abdullah Hamad will discuss his cases. I will start with the problem of the fractures of the neck of the femur. In young adults. We know that this is a fracture that represents a great challenge to orthopedic surgeons, and it has been considered as an fracture. In the past, before the era of arthroplasty, it was a fracture that has a high mortality rate, and then after arthroplasty there is a lot of problems. Despite the modern techniques of treatment, most of the series represent 5 to 15% non-union rate and 20 to 25% avascular rate. We talk about the area of the neck, which is between the head and the intertrochanteric area, and this area has characteristics as regard skeleton, as regard capsular cover, and as regard vascularities. The capsule anteriorly is extended to the intertrochanteric area with a thickened iliofemoral ligament, which has a reasonable blood supply. One in the back of the posterior view, it shows that the capsule cover to the same area. And there is a skeletal configuration representing primary compression trabecular system, primary compression, secondary compression, and also some areas with less dense bone in between these trabeculae. The calcar femoral is a dense vertical plate of cancellous bone within the neck of the femur. It originates at the posteromedial portion of the shaft under the receptor trochanter and radiates laterally towards the greater trochanter. It fuses superiorly with the cortex of the posterior aspect of the neck. It is important area for stability and for fixation. The unique blood vessel configuration is very important in this area because we know that the most important characteristic feature of the fractures of the neck of the femur that it has poor blood supply. And we know that the lateral epiphyseal artery is believed to supply most of the blood to the weight-bearing area of the head. It passes through the posterior tenacula of Whitbread. As regard the neck shaft angle, it is between 130 plus or minus 7 degrees. It is important also to know that there is these variations. Classification of intracapsular femoral fractures. There are 4 common classifications. The location of the fracture, either subcapital or other fractures, direction of the fracture angle, displacement of the fracture fragments, and the AO classification. The anatomical is subcapital or transcervical or basicervical. The fractures, according to the fracture angle, we know that the more horizontal the fracture, the more it is stable, and this is the basic of the Paul's classification. And the fracture displacement classification, which is the Garden classification, which is well known in our practice. Grade 1 and 2 are undisplaced, grade 3 and 4 partially and complete displacement, and this is one of the very common classification we use in the classification and in management. To diagnose clinically, it is obvious, but sometimes in non-displaced fractures, patients can come walking in casualty, and we have to suspect any patient falling down in elderly. We have to suspect that there is a fracture of the neck of the femur, and we have to be very careful. If it is displaced, it is obvious, and there is obvious clinical picture of external rotation and pain. Radiological examination, X-ray, CT, and MRI might be used. CT sometimes is used to diagnose undetected fracture neck of femur in biplane X-rays, and also MRI might show, as you can see here, might show a fracture which is not seen in X-ray. So this is the clinical presentation. Management usually either fixation or replacement, and usually when we talk about fractures in young adults, most of the cases our aim is to fix, to preserve the joint, because whatever the function of artificial joints are never like the normal ones, and replacement usually is done or is used when this fixation fails. And this is the idea of this webinar, is to see why some of these cases will need some sort of replacement if it doesn't heal. As regards fixation, there is a lot of ways to fix multiple cancellous leg screws, and also the direction of the screws are, there is a lot of theories like parallel screws or triangular shape, multiple ways of fixation. And also there is also some other methods to fix, like DHS with anterorotatory screws, nose pins, and in the past we used to have this Smith Peterson nails, McLaughlin's, and Jewett fixation to fix such a fracture, but the results of this fixation was not that perfect. As regard hemiarthroplasties, in the past we used to use Ostomore Thompson unipolars, and now the bipolar is the golden standard of the hemiarthroplasty, and total arthroplasty, either large heads or dual mobilities, are also used if we plan to have total arthroplasty. We have a very small case series done in our hospital in Hadara. It was 20 patients, but only 10 of them are under 50, and all of them were treated by internal fixation, and all of them started limited weight bearing 2 to 4 months after surgery, follow up at least 6 months. And we use the Harris Hip score for assessment, and X-rays for assessment of union. About 80% had good results, while 20% had unsatisfactory ones. When we analyzed the cases, we found that 75% of unsatisfactory results were under 50 years. That's why we have to be very careful with such fracture in this age group. And these are some cases which was used fracture neck of femur fixed by screws. Union was very good. The last 2 weeks we did arthroplasty for cases with fracture neck of femur in the past, and this is one of the cases, 29 years old female, fracture neck of femur fixed by 3 screws. History started 9 months ago when she had pinning, but the fracture did not heal, and this was the arthroplasty X-ray, and we did a cementless total hip for her. So this is one of the cases. The second one, this case had a fracture neck of femur 10 days before the arthroplasty, and it was Garden 4, and arthroplasty was done directly for her, dual mobility. These are some cases to open the discussion about the title of this webinar, why it is important, why this is unsolved fracture till now, in spite of all what we had as regard methods of fixation, theories, arthroplasties. Still, this is unsolved problem. Thank you. So now
دكتور ايمن، شكرا على التوك بتاعك. بس نوت يعني لو سمحت توصلوا الاكزير فارما الهوست ان في باناليست مش قادرين يبقى لهم اكسس للميكروفون والكاميرا، فيا ريت تامند الاكونت بتاعهم عشان يقدروا يخشوا. دكتور فؤاد زامل والدكتور حازم عبد العظيم واكتر من حد وهيثم وكده.
طيب حاضر.
ممكن يا دكتور تقول لي الاسامي بتاعتهم ويكونوا موجودين؟ يعني دكتور فؤاد بقى
دكتور حازم.
السلام عليكم. انا بقيت خلاص بانلست، بس اعتقد لسه دكتور حازم ودكتور هيثم ما شفتهمش على البانلست. ودكتور حازم بيه عبد العظيم.
والدكتور اكرم
دكتور حازم دلوقتي بقى موجود،
والدكتور اكرم حماد كمان يا جماعه.
مش موجود في البارتيسيبنت ده.
مش موجود في البارتيسيبنت.
ازيك يا دكتور فؤاد؟ ازي حضرتك؟ نور.
ازيك؟
اهلا وسهلا. اهلا دكتور ايمن، ازيك؟ اهلا وسهلا دكتور ايمن بيه. ازيك دكتور ايمن عبيد؟ ازيكم؟ ازيك يا عبد الله؟
دكتور فؤاد مساء الفل عليك. ازيك اخبارك ايه؟
اهلا طارق، ازيك؟
برضك مش عارف يدخل يا جماعه. الدكتور محمود مبروك يا عمرو.
تمام بقى دلوقتي موجود معانا يا دكتور.
اهلا دكتور فؤاد بيه. اهلا بيه.
اهلا دكتور عبد الله، ازيك حبيبي؟ اخبارك ايه؟
الدكتور حازم يا جماعه لغايه دلوقتي ما دخلش.
دكتور محمود مبروك برضو بيتهيألي كان موجود في الاول بيحاول يخش.
تمام كده دكتور محمود مبروك دلوقتي معانا.
والدكتور حازم عبد العظيم.
دكتور حازم عبد العظيم. دكتور ماهر حلاوه
حازم.
برضو كان بيقول ان هو مش عارف يخش.
الدكتور ماهر كان عمال يحاول يخش مش عارف يخش.
هو اسمه مش موجود عندي في الاتنديز.
ما هو عشان ما كانش عارف
ممكن يكون معانا يعني يدخل مرة تاني وهدخله.
دكتور حازم بيه برضه هل لسه معانا ولا مش برضه مش شايفينه على على البانلست؟
الدكتور بهاء قرنة كمان كاتب لنا ان هو معانا على الميتنج. دكتور بهاء قرنة.
تمام بقى دلوقتي موجود معانا يا دكتور في البانلست.
الو دكتور محمود بيه، ازي حضرتك؟ انا
دكتور
شايفك
محمود
اهو،
بيه.
انت كده معانا. ماشي ماشي ماشي، مع السلامه.
طيب دكتور عبد الله نبدأ
عبد الله are you connected يا دكتور عبد الله؟
نكلمه.
انا مش عارف انتوا سامعين معايا في الباك جراوند في ميوزك؟
في ميوزك في الباك جراوند بس انا مش عارف جايه منين دي. وقفت الميوزك. هو الدكتور عبد الله راح فين؟ اعتقد we need to move forward.
ممكن الدكتور ايمن سليمان بس
الدكتور
شيرنج سكرين يعني.
ايمن سليمان. دكتور ايمن. هلو
ايوه
دكتور ايمن ممكن ستوب شيرنج ذا سكرين، واذا
أوكي.
كان الدكتور عبد الله مش موجود دلوقتي فممكن الدكتور ايمن عبيد ستارت بريزنتنج.
تمام كده ستوبت
دلوقتي ستوب ده.
تمام.
دكتور ايمن عبيد are you with us now؟
شور انا موجود بس انا متهيألي كان عبد الله عايز يقول توك الاول.
ما انا
أنا
مش لاقي
معاكم
عبد
يعني.
الله. انا مش لاقي، عمال انادي عليه مش لاقيه، فشكله
طيب،
ديسكونكتد.
تحبوا اعمل ايه؟ ابتدي؟
ابتدي اعتقد لغايه ما يخش وبعدين هو يتكلم بعديك.
الا لو كان التوب مثلا كان الدكتور عبد الله عنده توبيك عايز يقوله
هو
مخصوص للدكتور
هو هيقول محاضره. انا هقول
كيس برزنتيشن.
كيس برزنتيشن.
طب هو دكتور عبد الله فصل ولا
فصل؟
لا عبد الله داخل دلوقتي خلاص.
خلاص داخل. طيب دكتور حازم عبد العظيم حتى هذه اللحظة برضك ما دخلش باناليست. دكتور محمود باشا ازي حضرتك؟
الله يخليك دكتور طارق بيه.
ازي حضرتك؟
كل سنة وانتم طيبين.
وانت بالصحة والسلامة. الله يخليك يا بيه.
وحضرتك طيب يا دكتور محمود.
الله يخليك.
طيب دكتور محمود ازي صحتك؟
الله يخليك. ازي حضرتك؟
ازيك يا باشا؟ ازي حضرتك؟
ربنا يخليك دكتور فادي. ازي حضرتك يا ريس؟ لسه الدكتور حازم ولا ايه؟
دكتور حازم لسه ما ظهرش.
لسه ما ظهرش برضه، ما
مع
اعرفش.
ان هو كان كتب ان هو هيفضل يعني يسمع حتى من غير ما يقدر يشارك لغايه لما
معانا كده الدكتور حازم اهو ظهر.
دكتور حازم دخل الحمد لله.
طيب الحمد لله كده تمام.
دكتور عبد الله حماد بقى.
انا اشكركم جدا على المحاولات
المحاولات المضنيه.
مساء الخير عليكم كلكم.
مساء الخير يا دكتور حازم.
ازيك دكتور حازم بيه؟ ازي حضرتك؟
ازي حضرتك؟ ازي صحه سعادتك؟
يلا
كل ده مستنيينك يا ريس، مش عايزين نعمل حاجه من غيرك.
يا عم الله يخليك. لا ده انا شايف الامر ماشي حلو جدا اهو.
طيب
يلا توكلنا على الله، اتفضلوا.
توكلنا على الله، احنا منتصر.
عبد الله حماد معانا اهوت. عبد الله حماد.
ايوه
يا
انا
دكتور عبد
موجود.
الله جاهز تو بريزنت؟ دكتور عبد الله
ايوه
جاهز to
ايوه
share
ايوه
your
انا موجود.
screen share your
يس
screen
اوكي
and start please.
اوكي. اوكي is it now clear؟
تمام.
اوكي. اولا انا بحب ارحب باساتذتي واخواتي الكبار كلهم، واشكر الدكتور ايمن على ثقته الغاليه يعني. وطبعا الدكتور ايمن استاذي، انا ما اجروش اقول صديقي، لا هو طبعا استاذي
صديق عبد الله، صديق.
وتجراسي كمان. احنا ربنا عمل الجزء الاصعب من الانترودكشن. So I will proceed for some evidence about fracture fixation in young adults. I start my presentation by
يا محمود انت قايم رايح فين؟
قاعد والله مستني بس بعد الظهري.
اصل عبد الله حماد سكت، فانا مش عارف هو سكت ليه. فانت قلت
مش عشان
اعرفك ان انا واخد بالي من كل واحد قاعد فين.
لا لا مش بسببي.
اصل الميكروفونات دي برضه فاضحه يا باشا. الواحد لما بيعمل صوت عنده الكاميرا تفتح على طول.
فين الدكتور عبد الله حماد؟ السلايد واقف. عبد الله حماد فصل.
disconnected عبد الله شكله.
طبعا مشكله نت اكيد.
شكلها كده عنده connection problem.
عندي استفسار للدكتور ايمن سليمان بيه لو سمح يعني، قبل ما لو في الحاله اللي هي الكونفرجن بتاع الفيلد فيكسيشن ب 3 كانسيلا سكروز ل توتال هيب ريبليسمنت يعني why did use اللونج ستيم؟ يعني why didn't الكونفنشن just الستيم العادي بتاعنا، طالما ان هم يعني 3 كانسيلا سكروز في منطقه التروكانتر بالكتير، يعني ليه انا هستخدم لونج ستيم واعمل يعني الشغل ده كله، برغم ان ممكن الكلاسيك توتال هيب ممكن يؤدي الغرض يعني سيمنتريس برضه.
يعني هو احنا معظم طبعا الكونفرجن اوف ا فيلد كانسيلا سكروز فيكسيشن في نيكو فيمر ويوز الستاندرد سيمنتال ستيم.
ايوه.
في some يعني سبيشال كيسز زي مثلا عيان يكون على رينال داياليسيس بون ويك، ممكن ساعتها نحتاج يعني لونج فيكسيشن لو احنا مش مطمئنين قوي من البون كواليتي.
يعني ده واحد منهم، يعني ده في سبب خلاني اعمل اللونج ستيم. انا قصدي كده يعني ده ايفن في ناس ايفن في الكونفرجن اوف فيلد فيكسيشن باي دي اتش اس بيعملوا الكلاسيك او الستاندرد ستيم يعني انا ممكن اعمل كلوجر للهولز ديت ببون جرافت او بسيمنت وات ايفر الميثودز واشتغل برضه بكلاسيك ستيم. فانا برضه بقول ليه لونج ستيم في حاله اصلا فيها ايفن 3 كانسيلا سكروز وات ايفر الباثولوجي. انا ما اعرفش طبعا اذا كان ممكن الرينال فيلر والحاجات ديت لازم يبقى معاها لونج ستيم ولا لا. ده رايي، انا ما اعرفش برضه، انا بسال يعني عشان اسمع اراء.
لا كلام حضرتك it is the rule ان احنا we use standard stem in conversion from a failed cancellous screws fixation for neck femur. يعني ده
اوكي
الستاندرد بتاعنا. انما
اه
sometimes البوم كواليتي ما يبقاش يعني accepted او يبقى weak. we might ساعتها we look for more fixation distally.
اوكي ثانك يو فيري ماتش. انا بسال برضو لو على ما يجي الدكتور عبد الله، لو في حد يعني عايز يعلق او يعمل كومنت، لان انا الحقيقه في رساله دكتوراه معايا شغال على even الكونفرجن اوف فيلد فيكسيشن باي دي اتش اس، بنعمل الستاندرد ستيم يعني. فانا برضو لو في ناس لها راي او حاجه زي كده يا ريت نسمع الاراء يعني لغايه ما يجي الدكتور عبد الله يعني.
دكتور محمود بيه، لو تسمح لي اقول لحضرتك كومنت.
اتفضل
هو
دكتور فؤاد.
حضرتك جايز كنت يعني تذكروا، انا كنت في سيريز كبيره كنا عملناها في القصر العيني واستمرنا عليها، اللي هي بالذات فور تروكانتريك فراكتشرز.
انا حضرت مناقشه رساله عندكم في القصر العيني مع الدكتور
تمام
الحقيقه طارق عبد الشافي ومع حضرتك على حاجه زي كده من فتره يعني.
تمام. فحتى يعني تاكيدا لكلام سعادتك، في الاول خالص عدد كبير من حياته، حتى انا كنت ساعتها وصفت حاجه اسمها ذا نيك اوف فيمر باترن، اللي هو بعتبر انه كانه فراكتشر نيك اوف فيمر ومعاه كوميونيوشن في الميتافيسيس، يعني فيتحول من تروكانتريك لنيك اوف فيمر بلس تروكانتريك. وكنا في اول مجموعه من الحالات، يعني جايز اول 20 او 30 حاله، كنت دايما بحط لونج ستام، بالذات لما بلاقي ان الكالكر او اللاسر تروكانتر مكسور. I never believed خالص في حاجه اسمها كالكر ريبليسنج. انا بعتبر ان الكالكر ريبليسنج بروسيس ده بروسيس فاشل، ما بينجحش يعني.
لكن معلش فؤاد، اسمح لي دقيقه واحده ان انا اقطعك. في ناس معانا ما بيتكلموش عربي وبعتين رساله we would like to follow the discussion.
Okay, I'm sorry, I apologize.
Can we continue to make our discussion in English, please?
Yes, sure.
Thank you.
Sure.
I'm sorry for the interruption.
It's okay. Thank you, Dr. Ayman. What I was trying to say is that we had a research on the hip replacement in trochanteric fractures, and especially for cases whereby we used to describe a certain pattern that we call the femoral neck of femur pattern among the trochanteric groups. And we all knew that there was a trend, and especially in my practice and in our practice, in the first maybe 25 to 30 cases, I used to replace these trochanteric fractures usually with a long stem. I don't believe very much in what we call the calcar replacing prosthesis, but I always used to use a longer stem for such fractures. But the difference in these cases is that after maybe 25 to 30 cases, I started to realize that we really don't even need a long stem for these cases. So a lot of the cases we've done, we started to use standard stems with repair and reconstruction of the area around the lesser trochanter, what we call the calcar area. And we used to repair that with wires and KYs and screws and stuff like that. And even with this fracture pattern, we used to put standard stem. So this sort of confirms the comment by Professor Mahmoud Mabrouk about why do we need to bypass a weak area in the metaphysis, or presumably weak area by the holes of the C screws. To my practice, I don't think we need that. The standard stems would work beautifully. And even if you have some deficiency in the calcar area, you can even repair that. You can reconstruct it with wires and screws. And in our practice, I've replaced quite a big number of these fractures with this use of a standard stem. There was no need to use a long stem. Thank you.
Thank you, Dr. Fuad.
Dr. Abdullah, are you ready to continue?
Yes, I'm sorry for the unstable net, but now, inshallah, I'm ready.
Go ahead.
So if we start over again, I'm sorry for this delay. We know that this is very debatable issue. So if you have this case of 30 years old female and the fracture is fresh fracture, I was preparing a poll question. Dr. Amr, are you ready for starting the poll question, please?
The first one, Doctor?
Yes, please. So what are the options for treatment? Closed reduction, tendon fixation, over reduction, tendon fixation, or arthroplasty? Please vote.
It doesn't allow to tick.
The panelists are not
Are not allowed.
allowed. You can allow panelists, Amr, if it's okay.
Okay. Carry on for the audience.
Okay. So can you see the statistics, Dr. Amr?
اوكي يا دكتور.
So it's actually it's very good. More than 90% of the audience are aware that in young persons we should go for fixation, and arthroplasty should be a salvage option only. And we have about equal percent of choosing closed reduction versus open reduction. We, inshallah, can see what is the evidence beyond this debate during the presentation. If we go to the second common question, if we are with the same case, what is the fixation option you will go for? Is it cannulated screws, dynamic hip screw, or you can opt for maybe other new options? Yes, please. Dr. Amr, please, statistics. So it is about 2/3 of the audience and probably the panelists will choose the cannulated screws, and only 1/3 will choose the dynamic hip screw. And we have a minority that are aware that there are other options that we can discuss during this presentation. Thank you for participation. We will carry on. I think we should agree that the two main problems in young adults is the reduction of the fracture and the fixation. There is a third minor problem, but it could be problematic if we are not aware, that in young adults with very high energy trauma, we may miss a femoral neck fracture in association with an ipsilateral shaft fracture of the femur, and the percent is about 6 to 9%. Usually these fractures are undisplaced because the femoral shaft will take the most of the energy, and usually if they are picked up, should be an easy job to start with the pinning of this neck fracture before going to the fixation of the fracture of the femur. So my objective in this talk is to give an update regarding reduction and fixation techniques. We know that the arthroplasty is the gold standard in elderly population. This is a very old randomized controlled trial from GBGS, British, and these data were from Swedish registers, and they enrolled more than 400 patients, and all patients were above 70 years of age. They observed a very high failure rate in fixation group, up to 43% versus only 6% in arthroplasty group. So this is no more a debate in elderly population, as I think we all know and agree. Even arthroplasty could be accepted for middle age, and this is a recent article, again, a randomized control trial in the New England Journal of Medicine, comparing the results of total hip arthroplasty to hemiarthroplasty in fracture neck of femur. But I brought this article due to the inclusion criteria that they included age 50 and plus. So this is an accepted method of treatment if the patient is 50 or above to have an arthroplasty. And by the way, the primary endpoint of this randomized trial was secondary hip procedure within 24 months, and there were no difference between total and hemiarthroplasty groups. In our practice in Egypt, I think we all provide patients in 50 or plus this method of treatment. using also modern techniques like dual mobility hip replacement. And this article is from our group in Alexandria, denoting the functional outcome and health-related quality of life after dual mobility cup total hip replacement in middle-aged Egyptian population. But if the age is less than 50, we should all agree that we should try fixation first. This is the only consensus, but how to fix, how to reduce, what is the method of fixation, what is the timing, all of this is debatable issue. And this was a questionnaire for more than 5,000 surgeons. And they were asked the preference as I asked you, less than 25% of them choose open reduction and more than 75% choose closed reduction. And all of them agree for cannulated screws in undisplaced fractures. There was a still ongoing debate in displaced fractures for dynamic hip screw versus cannulated screws. And the timing of fixation, the ideal timing of fixation when they asked about were variable between 8 hours up to 24 hours. Despite this debate and despite the variation in fixation and reduction methods, we all observe and we all aware about the very high complication rate following young femoral neck fractures, like Dr. Ayman Suleiman just said. It's an unsolved fracture, still unsolved fracture. So in this meta-analysis in 2015 in injury, they enrolled more than 105,000 patients in more than 40 articles, and they found that the pooled reoperation rate was 18%, with a 14% avascular necrosis rate, 10% non-union, 10% implant failure, 5% infection, and 7% malunion. Still very high rate of complications. This is especially even true more for the more vertical and more displaced fractures, despite the innovation of many fixation methods like using a fourth screw or using a dynamic hip screws and rotator screw, or changing the configuration of the screw, putting a transverse screw to be perpendicular to the vertical fracture line. Why this high complication rate? Because the problem in this fracture is the vascularity, and the second problem is the stability, which is partially modified through the choice of the implant. There are added problems that is not mentioned for young adults, like the bone quality and comminution, which is maybe more important in elderly population. For this, the Garden classification and the modified classification, grouping type 1 and 2 as non-displaced versus displaced for type 3 and 4, is a method to predict the quality of vascularity of these fractures. And the whole classification, which entails the orientation of the fracture line after reduction, which is an intraoperative decision, entails the stability of the fracture, with more vertic fractures are more unstable. For undisplaced fractures, it is no debate. There is no debate. Internal fixation is the gold standard, whatever the age, to prevent second displacement. And the method of choice is the cannulated screws, as we all know. But for displaced fractures, we should have these 3 stages: the reduction, then identification of the orientation of the fracture line, then the choice of the implant. Reduction could be either closed reduction or open reduction. We have all the method of closed reduction with the hip extended, and we have the new method with the hip flexed 90-90. And with this hip flexion, we have 2 contradictory methods. The most accepted is to pull the whole limb in the line of the femoral neck axial traction on the line of femoral neck rather than the line of femoral shaft, to affect the reduction using the orientation of the capsular fibers, and then you lock the fracture in extension and internal rotation to stabilize the fragment. If you are not happy with the result of your first, maybe second, and finally your third attempt, you should go for open reduction. We can choose between direct anterior approach, like Smith-Witherson approach, or anterolateral approach, like Watson-Jones approach, which is more useful in more basal fractures. And there are many methods of reduction, as we can, inshallah, discuss in the coming slides. Whatever the method you do, open or close reduction, your aim is the anatomical reduction, because this is the most important and also the modifiable factor that is in your hand to control partially control the outcome of this fracture in terms of union rate and less complication. So the quality of reduction is the single most important factor affecting the results. There were some debate in the last decade or 2 decades whether the method of fixation could affect the complication rate and the timing of the reduction. And this randomized controlled trial had proven that there was no significant difference between open and closed reduction in terms of complication rate at 2 years. And also if there is a delay for treatment with this fracture, so the more experienced surgeon was more appropriate operation theater settings, you can delay the treatment up to 48 hours with accepted results. So it is not that emergency as we were taught before. So the most important is the reduction. And reduction is a function of the alignment and the rotation of the proximal fragment to the distal fragment. In this case that we took your opinion about, we have very, very bad uncontrollable factors like displacement, poor vascularity being the fracture subcapital, and comminution and instability. And the fixation, because the surgeon opted for closed reduction, is not optimal. The reduction is not optimal. And we could all predict that this will fail sooner or later, especially with the shortening and varus collapse of this fracture. So this is the most important message from this presentation, that whenever you're dealing with fracture neck femur young adult, should not let your mind think about that this is a salvage operation and you will go for a total hip replacement and the total hip replacement is inevitable. No, you should do all your effort to reduce this fracture anatomically, and you should have all the tools and expertise to do this job. And then you fix the fracture in a good configuration and a stable manner, because most of these fractures, if treated properly, will unite. Although the complication rate is high, it's 20%, but you can save 80% of the patients from doing a hip replacement at a relatively younger age. And we all know that femoral leg shortening after hip fracture fixation is associated with inferior hip function. So after reduction, we should go for a stable internal fixation to prevent this collapse. And this is a result of a very famous trial called fixation using alternative implants of the treatment of hip fractures, or FAITH trial, which was published in the Lancet 2017. And this is a secondary analysis of the result at Journal of Orthopedic Trauma in 2019. To have a good reduction and stable reduction, we should be very familiar with the radiological landmarks, both pre-operative and intraoperative. And because the fluoroscopy is a very dangerous tool, it can deceive us very easy because we move it in many directions and reproducing many lines. These lines are denoting different radiological parameters, and these radiological parameters reflect different anatomical areas. So one should be very aware about the orientation of the proximal fragment to the distal fragment with the restoration of the neck shaft angle in the AP view and restoration of the straight central line between the center of the femoral head and the center of the shaft. One should not be deceived by the shadow of the greater trunk over the anterior or posterior necklines. So the posterior neckline is more reproducible in the X-ray because the anterior neckline has to be very clarified by special oblique views due to the overshadowing of the greater trunk in this lateral view. Also, you should orient and adjust the rotation of this fluoroscopy machine to calibrate the anteversion of the femoral neck. So in the AP view, you should restore the neck shaft angle. If it is more than 160, it is excellent result. If it is less than 140, it is fair result. While in the lateral view, you should strive for a straight line joining the center of the head to the center of the neck and then the center of the shaft. Another method is to see the smooth S in the inferior and superior, also anterior posterior cortices. As we said, the posterior cortical line is more reproducible in the fluoroscopy. And I recommend all of us to review this educational video on the AO website about the technique of intraoperative imaging of the proximal femur. In this video, you will see how to interpret in a precise way the X-ray in the theater in the AP and lateral view. If the reduction is not good at the closed level, we should strive for open reduction. And here, this article in Journal of Orthopedic Trauma is a very useful article for relatively new techniques for reduction. So, in spite of using fracture table, the author preferred to use a femoral distractor. So, the fracture table will not hinder the imaging, and the femoral distractor will have a more effective and more axial distraction at the fracture line. And this is a lateral incision for the fixation. Another method is to use the 3.5 millimeter tab at the joystick in the femoral head, while advancing the pins just at the fracture level. So if you have the reduction, you just fire the pins. Another method is to direct clamp reduction using vapor clamp. Even more aggressive is using collinear clamp and pelvic reduction clamp in two orthogonal planes to both preserve the valgus angle and then effect more compression at the fracture line. Even the Young-Bluth large pelvic clamp may be used to reduce the anterior tilts, which is a usual finding in the femoral leg fractures. This is the standard fixation method, which is the cannulated screws in inverted triangular configuration. The screws should be parallel to allow compression. There are some papers that were more toward putting the entry point lower than the lesser trunk to have a more perpendicular orientation to the fracture line. But according to the most recent evidence, there is still a very high risk of subtrochanteric fractures if you are starting below the lesser trunk. If the fracture is vertical or basicervical, or if there is high posterior comminution, you may opt for a more stable implant, which is the dynamic hip screw. And again, this is the FAITH trial, which was comparing the dynamic hip screw to the cannulated screws. And the conclusion that in terms of reoperation rate, the sliding hip screw shows no advantage. Some patients may benefit from dynamic hip screw especially in vertical fractures. But the dynamic screw is associated with more complication, especially the avascular necrosis. And at the end, they have no sufficient evidence to preference of one of the two classic methods for fixation of the femoral neck fractures. Other fixation methods include putting a fourth screw, which could be in a transverse orientation, so to be perpendicular to the vertical fracture line of Powell type 3, using a fully threaded screws so that the collapse of the and backing out of the screws is less. Using a helical blade in the dynamic hip screw called the sliding helical hip screw, and putting what's called medial buttress or calcar plate to prevent varus collapse. Even you can put another anterior plate to reduce the anterior tilt of the femoral neck fracture. And this medial buttress plate is a relatively new method for augmentation of the fracture. The author in this paper described the technique. They use the direct anterior approach identical to the direct anterior approach to the total hip. And after completing the fixation with connected screws, they put the limb in external rotation and abduction to get the medial side of the neck in the surgical field, and put a third tubular under contoured plate to effect the compression and buttressing at the area of the calcar. Some of evidence was emerging that this plates is associated with non-union due to the distraction at the fracture site. Locked plates were tried, but according to the most recent evidence, they are catastrophic in terms of early failure and reoperation rate, because they are too stiff and does not allow compression. The future directions include combination of the advantage of multiple cannulated screws for multiple fixation points with the controlled sliding of the sliding hip screw in one device. So in this device, you have a side plate that allow compression, and the screw is allowing self-telescoping for controlled post-operative collapse of the fracture to face the compression. And these relatively new devices have some promising results, but still too early to judge. This is another identical device, which is more familiar in Europe. Finally, I end with take-home message that reduction is the single most important factor, and there is no difference between open reduction and the closed reduction in terms of outcome. So if you need open reduction, please do it. Still, the classic methods are connected screws versus dynamic hip screw in displaced fractures, and the debate is still unsolved, which is more appropriate for this fracture. Novel fixation method may be promising, but it's too early to judge, and still we have high complication rates. Thank you very much.
Thank you, Professor Abdallah. Very clear talk about different methods of management of such an unsolved fracture. I would like to see if there is any questions about this talk.
I think, Dr. Baha, I think we have to add it for the take-home message that this fracture need to be done by a senior, as not by a junior. This is very important because a lot of cases is coming during night and is being done by junior staff, and that's why you have a high rate of complications.
Totally agree, Dr. Baha. Actually, I said that timing is not the most important factor. And I said it during the presentation, but it's worthy to be written at the take-home message. I totally agree. Thank you.
I disagree. It's not a matter of senior or junior stuff. Essentially, it is a kind of perfection. When we are talking about reduction of the neck of the femur, we got to talk about the anatomical reduction, or the best reduction we can ever have, and together with some kind of maybe valgus deviation, of valgus position of the neck, if it is possible. I'm not saying that senior surgeon is not targeted to do it, but it's not always in need of that. It has to be supervised by somebody who understands quite well the position of the reduced neck of the femur. Thank you.
But if we see a lot of cases, and you can see that there is a lot of mistaking from the surgeon. It's not from the fracture itself. We consider the fracture, but we forget about the iatrogenic reduction, malunion, replacement of screws. All this, I think it is a matter of something is being doing by surgeon.
Well, if a senior surgeon have done it and it's not reduced, then you are going to get the same result. So it needs perfection of the result, perfection of reduction. And it needs a kind of learning curve when you go to support your resident and your younger staff to be able to understand what are the maneuvers that can lead you to the perfect reduction, and then the way the screws are arranged and so forth. Not only just you do the exercise always yourself, considering that, or by senior staff, considering that it should be done only by the senior staff. This is what I mean.
Dr. Abdullah, if I may ask you a question and a comment. And I noticed, thank you very much, طبعا, for the very, very well done presentation, which is very elaborate, وفيها a very good evidence based. And I just noticed a mark of the age اللي حضرتك حطيته at the beginning, around the age of 50. To my knowledge, most of the literature, I think, would discuss that the upper age limit whereby we always strive for fixation is not 50. It is probably in the order of 65 in a lot of the literature, and sometimes some paper would go as down as 60. Because I think the age of 50 is too young for an upper limit of consensus with fixation. So the consensus of fixation, and please correct me if you've read something more recent than what I know, the consensus of fixation is up to the age of 60 to 65. And then beyond the age of 65, if it's displaced, the literature would start to shift towards using arthroplasty rather than fixation. But fixation is for any patient below the age of 65 to 60. Am I right, or do you have another comment?
Thank you, Dr. Fuad. I think young adult is, by definition, by WHO, is up to the age of 60, as you just mentioned. And most of the literature support your view. But the aim of getting this paper in the presentation, that it could be even accepted if you are faced with displaced fracture. The patient is 50 plus, and you are faced with bad prognostic factors. You may acceptably, especially in Egypt, as a common practice, you may acceptably do total hip replacement. I was in discussion with Ahmed Al-Baquri, and he's here now from Plymouth, and he said that it's different between centers. So in some centers where the arthroplastic expertise is higher, they may go for arthroplasty at a lower age limit, but in other centers where the trauma expertise is higher, they extend the fixation to 60 or 65. So if can Ahmed please get it and complete the comment, please.
Yeah, thank you very much, Abdullah. Thank you, Dr. Fuad. The thing is, the consensus for fixation versus arthroplasty for neck femur fracture is below the age of 50. Any patients below the age of 50, I think they do better with the fixation first. Definitely patients above the age of 65, as you said, they do better with arthroplasty. So there is an area which is from the age of 50 to age of 65, which actually there's no much in the literature saying which way you should go first. I think it's so this is an area of debate. The Abdullah showed the FAITH randomized controlled trial from McMaster, I think. That was published 3 years ago, and they used a lower age, which is age of 50, and they didn't find any difference between in reoperation rate between arthroplasty and OF. But we get your point. I think personally is chronological age is something, but I think physiological age is the main thing. So if you have someone is 65, but they are really fit and active, why not fix them? However, if you have like someone is in his 50s, but they have lots of medical comorbidities, they are ASA grade 3 or 4, and you don't want to have another operation in a year or two, in those cases, you might discuss with them the option of arthroplasty.
Okay, thank you for your answer, Dr. Ahmed. My only uneasiness about this issue is because we've also had another webinar some weeks ago, and we discussed this period of age that we mentioned the enigmatic age. I don't know if you've attended that webinar, when we actually discussed the issue of the debate between the age of 50 and 65. And at that time, there was some general terms that we use whereby if they are between the age of 50, and that's something which has also, I've run across in the literature, that if you go to this enigmatic age, this debatable age between the age of 50 and 65, perhaps it hasn't been published in the literature, but what would be sort of a trend among surgeons is that if you have somebody between the age of 50 and 65 and you manage to obtain a closed reduction on, then definitely that would be a case for fixation, because they are still below the age of 65, which I think is the upper limit for fixation anyway. We might debate about whether you would go as far as pushing it and do an open reduction in somebody between the age of 50 and 65. And that's debatable, but the literature, as you say, has not actually decided whether we should shift the balance from a choice of arthroplasty versus fixation and vice versa. The one little remark that you've mentioned that has sort of now stimulated me to answer is that below the age of 50, if you say that there is an evidence in the literature that doesn't show any difference between the fixation and the replacement, especially if you've got people with experiences in replacement, especially if you're using specific type of implants, which you didn't say, but other people were mentioning, is that the end point of whether or not you go back to surgery within 24, 48, 5 years, or even 10 years, I don't think this is a good endpoint to answer a question in that respect, because if you replace somebody at the age of 40 with an arthroplasty, you're bound to have a good result and not needing to revisit it for another 20 years anyway.
Sorry, Dr. Fred, I said above the age of 50 and not below.
Yeah, I know. I'm just saying. Yeah. No, that's what I'm saying. I'm saying above the age of 50.
Yes.
Above the age of 50, if you say that there's no difference between doing a fixation or a replacement, I'm sure that if you apply this principle at the age of 45, you would probably find an ambiguous result that you cannot also find a different statistically significant manner, because if you do a good hip replacement at the age of 40 or 45, this hip is supposedly surviving for another 20 years. So if you leave the surrogate endpoint visiting the hip for another surgery up till the age of 24 months or 3 years or 4 years after the initial index surgery, you're not going to find any difference. So I think that there is an age group whereby claiming from a result that you did not find any difference, the result will show you no difference, but that no difference finding is of no clinical significance. That's what I'm saying.
I think if I'm allowed to make a comment, this debate will stay forever. The gray age, which is between 50 and 65, this is a gray zone. and the debate in
معلش
this will
اقطعك في
stay
حاجه
forever. Yes,
الدكتور ماهر حلاوي بيحاول يدخل ومفيش كونكشن عنده
انا بعت كونكشن على الجروب اللي انا دخلت بيه.
بعت لي على تليفوني.
اتمنى كمان دكتور حازم عبد العزيز معانا في البانلست، وكمان سؤال مهم يبقى معانا في البارتيسيبنت يدخل البانلست برضه هنستفيد من حازم لو ينفع.
انا بعت لهم. what I'm saying, this debate will stay forever, but I think that as Dr. Ahmed al-Baqouri said, there is a physiological age, because sometimes you see somebody which is 55 but physiologically is about 65 or even more, especially here in Egypt. Maybe in Europe or in North America or something like this, 65 is still a young patient, as the WHO classified the age up to 65 is a middle age. It's not a young adult, as Abdullah said, is a middle age.
Which you use in your own paper, Dr. Tariq, remember?
Yes, I know, but yes, but you find even in the literature people coming down with the age of arthroplasty to 50 as well, as Abdullah showed the FAITH trial, which is 50, and this is in literature. So I think this will be debatable forever. So we're not going to lose much more time in this. I think we are ready now for Ayman Abid to show his cases. Professor Ayman, are you following?
Yes, I am. Starting with the share, I hope you can see.
Yeah, go ahead.
How is that? Is that working?
Yes.
Okay, so it's always a pleasure to join my friends and to be in the Egyptian Pelvis and Hip Society symposia and webinars. And I've chosen to talk about case scenarios. Let's perhaps focus in what has been said and say if it works in all patients or not. This is 17 years old, and I think this we can all consider as a young adult. 17 years, she tripped up the stairs and developed this fracture. She attended to the emergency department within hours from the accident, and this was the X-ray taken. And you can say that it's not the perfect X-ray, with some errors in the X-ray, some metal in her trousers, and the zip is appearing. But this what was taken in the emergency department. Any comments on this X-ray? She's 17.
My comment is on the left hip, which I can see the neck of the femur. Does it look like very normal? You can see it's gouged from the inferior cortex or something like this.
Osteomalacia.
Yeah, I don't know what's wrong with it.
Vitamin D.
She's 17 years old.
She's 17.
Yes, yeah.
She's 17.
Yes.
Well, I think the bone trabeculations at the word triangle may give a kind of remark that this is osteoporotic osteomalacic patient. Some discussion has to be done about this. Details of vitamin D, bone densitometry, details for the general health, malabsorption syndrome, and so forth. I think the appearance of
would we ask for investigation before fixing, or should we proceed for fixing?
Most of the investigations can be done within hours. Most of the needed investigations can be done within hours, and these are not going to affect that much the policy of doing anatomical reduction and internal fixation by all means. But it's going to give us some clue about the further treatment of the case.
Okay. Well,
Dr. Ayman, may I add that this fracture should be classified according to pediatric classification? So it's,
I don't think so. Well, this is I've used the physics. She's 17 already, and I don't think a girl at the age of 17 is still child. To my knowledge, the pediatric hospitals would receive patients up to the age of 15, despite the fact that they might have already passed the skeletal maturity at the age of 15 for girls, but they still receive females at the age of 15, pediatric. This is when I was in Alderhay Pediatric Hospital. But beyond the age of 15, beyond the age of 15, patients are referred to the adult department.
This is the age of consent in UK. As far as I remember, was 15. Okay.
Okay, so shall we proceed? Because we have a long story. I'm retrieving all these X-rays retrospectively, as you may imagine. So yes, it is doubtful whether this lady has a metabolic disorder that has resulted in this pattern of trabecular arrangement on the in both hips. We can see that the bone is very osteoporotic, but the surgeons proceeded to what should be done for someone who is 17. And performed the fixation within reasonable time. Any comment on the internal fixation, the arrangement of the screws or the reduction?
It looks adequate. Adequate reduction.
The pubic reminds there is a fracture or osteoporotic or rosa zone, and the pubic remind. And the pubic remind. It is looser zones, this?
Yeah. Well, yes, we can observe that there is generalized osteoporosis, and she is likely to have a metabolic bone disorder.
As regards fixation, it's adequate.
I can see, is it a bit in varus compared to the other hip, a small degree of varus? This is maybe the only comment? Maybe. Neck shaft angle.
The neck is shortened. Maybe over compression. The neck is short. You can see the lesser trochanter is of equal size on both sides. So this means that they are in the same degree of rotation. So the neck, for sure, it is shortened here.
And inverse.
It is common, and it is inverse also.
Yes.
A touch of inverse, yes, I would agree.
But anyhow, I think the word adequate, which was said by Professor Khadraoui, is quite applicable here.
Okay.
Some compression at the fracture site, even if it leads to something like 1 centimeter or less of shortening, wouldn't affect the result if the fracture heals.
Yes.
Okay. It was hoped. She was discharged from the hospital, and 4 weeks later, this was the X-ray.
It's because of the bad bone quality.
Very bad bone quality on both sides.
But
anyway,
no clue about the bone disease which is causing this.
Well, I saw her at this stage. When she had full investigations, the parathyroid hormone was around 700 or so, which is 10-fold the normal. And further collapse at the fracture site. She had a scan for her parathyroid gland that revealed an adenoma. And what to do at this stage. She's confirmed now. She's hyperparathyroidism with an adenoma. Adenoma in the parathyroid gland.
Can I suggest something?
Please.
So I can see here that the area around the screws are loosened and the head is subluxed, together with more shortening of the neck than what we have seen before, and with coxavara.
Okay.
Now, I would start urgently to go for parathyroidectomy, leaving one gland and removing the adenoma and the rest of the glands. For sure, this is important, and this can be done straight away, and its post-operative time is something like 3 days. Then I will be planning to do to deal with the non-union of the neck of the femur together with this subluxation, in a sense of making the triple attack, giving giving the chance to lengthen the neck by the bone grafting, doing subtrochanteric osteotomy to improve the varus position, and at the same time getting some kind of valgus, and to fix the neck to the shaft, to fix the head to the shaft by a kind of static fixation first, by fully threaded screws. This is hopeful to go on with healing if the process of parathyroidism is controlled and reversed back, together with administration of the medical treatment.
This is obviously a great plan. I hope it works.
Dr. Ayman, no infection,
at this stage, no. Well, I can't see an evidence
because
of
of
infection.
loosening. يعني it's يعني we know that losing from the hyperpara, but could be also attributed to low-grade infection.
Yeah, well, it is to be taken into account. Obviously, if we plan for revision of fixation. But at this stage, when we recognize that she's hyperparathyroidism, I don't think we can intervene until the adenoma has been removed. What do you think?
Yes, sure. You should correct the hyperparathyroidism first before embarking on anything.
Okay, so I'll take it from your plan, and has been agreed by the panel. We'll send her to have the parathyroid adenoma removed first, and that's what I did. Okay, I sent her on the assumption that she would get a quick surgical procedure and come back to me when the parathyroid gland is removed. Apparently, the removal of the adenoma has taken her into a phase of hypocalcemia, to the degree that she remained for a few weeks, a month, and didn't appear again. What had happened with the general condition, I wasn't sure at this stage. So at 6 months, she appeared with this X-ray. You can see that the bone quality is not perfect. She's been wheelchair bound for some time. There is no mobility. There is further subluxation of the head, and I can see on the lateral view that it could be that it is fully dislocated. She's now 6 months. She is in a wheelchair, can we do anything at this stage? Professor Hazem Al-Hazim, you suggested before shortening the neck or lengthening the neck with some bone graft and refixation?
No, I don't think so. No, this is not suitable for reconstruction of the proximal end with a good hope. I mean, it can be done, but the hope is the chance to get a good result is very remote. I wouldn't dare to do it.
I just have a question, Dr. Ayman, if I may. I don't find a very clear to my mind explanation why the subluxation and dislocation happened. I mean, to me, a failure of a femoral neck fracture fixation would usually tend to leave the femoral head inside, and the rest of the fixation.
I can explain this subluxation with is the shortening of the neck. It's gradual shortening of the neck, and resorption that resulted in subluxation, especially that she has lost the muscle tone, has been a wheelchair bound, as I said, for 6 months now. She passed with apparently a critical phase of hypocalcemia that she was treated until generally become well.
Okay, because my other concern would be infection, actually, to be honest.
Okay.
Infection can increase the chance of dislocation, but the cases which was in which the neck goes into severe kind of resorption, like what's appearing in front of us, will of course subluxate, simply because the acetabulum and the capsule we are not going to be able to maintain the head inside the socket. The head will come out of the socket, so it dislocates.
Yeah, I agree with Dr. Fuad and Dr. Hazem, actually, Dr. Ayman, sorry. It just looks like there is a resorption of the posterior wall as well. Did you get a CT scan? Because like it might be infection and shows like it's resorbing the capsule and the posterior wall.
Yeah,
well.
could
That's
be.
why it dislocated.
Yeah. I would like you to be in the last presentation for this young girl. Now, she's 12 months down the line. She, as you can see, further damage of the head happened. Was cutting through the screws. She's fully dislocated head out of the acetabulum. We can see that the bone quality has improved as a result of the correction of the hyperparathyroidism, removing the adenoma. But ESR and CRP was around 12. ESR, I think, first hour was 35, second hour was around 60. And she's in this situation. She hasn't taken any weight on this limb for the last 12 months. Now,
Dr. Ayman, I think now Dr. Ayman ready for 1 or 2 stage revision according to the situation inside the fracture site. If there is infection, maybe 2 stage, or as you have done already 1 stage, but I think no other solutions except for arthroplasty.
Did you do aspiration, Ayman?
No, I didn't. Be quite honest. No, the situation with patients with failed fixation is different from when you aspirate a loose hip.
Yes.
No, I didn't attempt even to aspirate this hip. I just realized and be aware that the ESR and CRP are high. Now, what would you do? She's now 18.
If I have got
quality,
if I have
quality
got
has improved, but I'm not sure if there is a way to reconstruct this hip. What do you think?
I don't think that the bone quality has improved a lot, because you can see here that the cortex is still thin. But anyway, she will have a total hip replacement, either as Professor Mahmoud Mabrouk said, 1 stage or 2 stages. If I have got a doubt about the infection and I cannot rule out infection in this case, I would take out the metal, take biopsies from inside and do a culture and see how things goes. If I prove it is infected, I will treat like 2 stages till the clearance of the infection. If it is clean, I will revisit the hip in 4 weeks' time and I'll do a total hip replacement. I think this is a safer way to deal with this, especially if I'm not sure it is infected or not.
Okay. Will you choose to perform a hip replacement in a 18 now, 18 years old female with this bone quality? What type of implant would you prefer, Professor Khadraoui?
For the acetabulum, definitely will be a cementless cup. For the shaft of the femur, I will see at the time of the surgery if it is holding a decent cementless stem. I will go through. If not, definitely I will go for a cemented hip. Well cemented extra stem will stay as long as the cementless stem. But I will make this decision intraoperative, because from the X-ray I can see that the cortex is very thin. It's very thin. It's door type 3. Okay.
Yeah, well, from what you say, I see that your preference is to use a cementless cup, and perhaps I agree if I can. But my worry with patients who are very osteoporotic, like this young girl, is whether a cementless cup would be the best option intraoperatively, whether I can achieve the stability and the primary fit that I would like to see in patients with cementless cups.
High friction cup can hold. High friction like it can hold. Maybe not, but I will put it as a first option. Definitely, I used to have a backup of cemented cups in all cementless cases. There should be a backup of cemented. Yes.
You mentioned something about if it is infected, you do it staged.
Yes.
If you plan to do it staged, what will you do? Will you only remove metal work?
No,
I remove the
remnant,
the whole hip. Will you use a spacer or not?
I'm not going to use a spacer, but I'm going to remove the metal, the screws. I remove the remnant of the head. I put a static spacer in the acetabulum, which is a ball of cement with a high concentration of antibiotics. And because I'm planning to revisit again in 6 weeks, she is a year chair bound, and if you put articulating spacer in her, it will dislocate after 3-4 days, and she will be in more pain. So I'll put a static spacer, take the metal out, take the remnant of the head, and prepare her for the second stage revision.
So your worry about articulating the spacer is instability, say?
Yeah, sure, because it was dislocated for the last few months. So there is no inherent stability in that hip.
Okay. Shall I proceed, or there is any more comments from the? Okay. I took her to theater preparing both, and I was prepared to see if I can perform a total hip replacement as I wish to do it. I prepared for a cemented stem and cemented and cementless cups. This was the head. We realized that there is inside the field there is purulence. And at this stage, I decided to do an articulating spacer as a kiwi hip. So it's a poorly cemented hip, as you can see. Cement is being placed on the surface of the polyethylene cup. No much pressure, just to hold it in position. And again, this is an antibiotic loaded cement. And an all poly cup. I did the same on the femoral side, and I prepared a kiwi hip. Cement is being placed on the implant rather than filling the medullary canal, just to cover the surface of the implant, and no attempt for pressurization of the bone cement. And I thought I would give her a mobile spacer to allow her mobility, because she has been wheelchair bound for some time, and until culture results would become available to see if I can go back and when I go back. This is the post-operative X-ray, immediate post-operative. You can see the drain and the skin clips. We grow staph from this from the specimens, and we kept her on IV antibiotic and oral antibiotics for 6 weeks. She disappeared for some time, and appeared a year after with the articulating spacer, and that was hair. So I think she has got a good range of movement and a pain-free movement with this articulating spacer. She's now 2 years down the line, and she doesn't like to change it.
Ayman,
So
this is
yes,
not,
please.
this is not a kind of spacer, whatever you name it, kiwi or whatever. This is a cemented hip, but this is not
A poorly cemented hip.
It is a cemented hip. It is a cemented hip, but you can
Yes,
say that.
but it is a poorly cemented hip. So
That's
if I
that's
wish
right.
to
You
change
can
it,
say that this is not a good.
anytime,
This is
I will
not a
change
good
it.
cementing technique, and the only difference between this and the cemented hip will be the longevity. So
That's true.
if she is
Exactly.
if she is lucky having a longer life with this hip, this will be in favor of her bone recovery from the previous disease. And then
Yeah,
one day,
that's what
one
I
day-
thought actually.
yes, one day you are going to revise it into what you feel that this is a permanent hip or this is a well cemented hip, and well, it may be of shorter lifespan than this.
يعني
You know,
Ayman, if
Ayman,
I may extend on what Dr. Hazem Bey just said, يعني I would like to ask you, if she came back to you after 6 months or 3 months and you went inside to remove that stem, don't you think you would have had trouble bringing out the cement from the stem?
No,
sure.
I wouldn't because simply you can see how did I do it. I placed the cement on the stem rather than in the medullary canal.
But do you think that
when you look at the cement mantle, it's very poor. It doesn't reach to the tip of the stem, so it will easily be revised.
okay,
You
because
know,
I think that some of these cement mantles that look deficient in some areas, when they are attached to the bone cortex in other areas like the lateral cortex, for instance, you might find trouble bringing them out, and you might end up needing to do an ETO if you really want to remove the whole cement. But then obviously she has spared you this revision anyway so far.
exactly,
Yeah, well,
exactly. You know, Ayman, the problem of the kiwi hips, that what you see now, the patient is satisfied and she is pain-free because she's a little girl and the weight is little as well, and she's walking nicely. The problem is you lose track of that patient because not all the patients are smart enough to understand that this is a poorly cemented hip. It should be revised after 3 months or so. So you lose track of this case, and the patient will start to feel some pain because of the loosening one day, and the patient will start to take some painkillers, and they will come back with a deteriorated bone stock from the loosening. This is the real problem of the kiwi hip.
I take your point. But I chosen the kiwi hip because it would allow her a pain-free range of movement. She has been a wheelchair bound for a year.
Yeah.
And I chosen this to allow her to take weight on this limb, and this is hopefully going to improve the build quality of the right lower limb, giving her some hope that she can walk without pain. And in the meantime, if in 2-3 years' time, if she appears in 5 years to have it revised, that's fine. It is cheap, just an expensive spacer, if you like to say. But as you can say, you don't know intraoperatively whether you will be on top of this infection or not.
Yes.
And you should be prepared to take everything out if it didn't work. It would be much easier to remove this from inserting a cementless hip or inserting a fully well-cemented hip. I'll take the word.
I'm not saying that we do a proper cementing in the first instance. No, I'll ask the question in the other way. So would we prefer to put a static spacer for a couple of months till the infection markers are down, and then we revisit the hip and we do a proper cemented hip replacement, that we know that it might stay for 25 or 30 years, or we do a kiwi hip and we lose the track of the patient, and we see the patient after 3 years or 4 years with a poor bone stock from the loosening, and the patient will come back when she is agonized by the pain, and definitely she with a poor bone stock. Which is better?
No, the question,
She was on a wheelchair.
Be like this, sorry.
She was on a wheelchair for 12 months. So another couple of months on a wheelchair, I don't think that this will change the behavior of her life, because she was on a wheelchair for 12 months. So it will be 14 months. And after this, she will have a proper hip replacement, rather than we give her, this is my opinion. I might be wrong, I might be right, but this is my opinion.
Dr. Tariq, I have, please, one question for both of you and one comment. For the question, I know from the practice of Dr. Tariq Khadrawi that he may prefer to do the debridement without putting a spacer at all for first stage. Am I right? And,
say again, Abdullah. Say again.
يعني, if you, Dr. Tariq, your common practice, if I'm not wrong, that you don't prefer any kind of spacers in the first stage, and you depend on only
static spacer. Static spacer.
Yeah.
Just a bowl of cement, and we put it in the acetabulum just to keep the space open, and it will. It's loaded with the high concentration of antibiotics.
But you don't prefer to violate the canal.
No, I don't prefer to violate the canal in a case like this. I'll keep the canal closed. Yes. Closed.
The second comment that may I drive your attention that we have multiple questions from the attendee side to Dr. Ayman.
Okay.
We'll see.
انا مش عارف اكسس بصراحه الاتندي شات لان انا فول سكرين، فممكن مش عارف الدكتور طارق يقدر
انا كله بيتكلم على I have a question about the parathyroid first. The second is parathyroid and the valgus osteotomy. The first question is about bone quality. So I think we have answered all the question during the talk or during the discussion. Okay.
I take your point.
أيمن.
أيوة سعادة الباشا اتفضل.
Because I'm an old surgeon, I have seen a lot of poorly cemented hips beforehand. Actually, what we called cemented hips before the era of, let me say, extra perfection technique or perfected technique of cementing. This was the style of the cemented hips at that time. And I would say that these hips were living for some time. The only problem here, which we may worry about, as Dr. Tariq said, is that these patients sometimes disappears. And this is not our fault. And Tariq, I can tell you that I have seen patients with girdle stone, because I was fond of only debridement and girdle stone without putting any spacers inside for quite a long time, until the spacers has improved and they appeared like a good hip, a good hemiarthroplasty, for example, I would say. Before that, we were doing debridement, closure on in and out tubes. The in will have irrigation and the out will have suction, and the irrigation can be also by antibiotics. And then we leave the suction for some time, and then the hip is closed. And these patients in a group of incidents did not appear again. They were happy with the girdle stone, walking on it, holding a stick, and because of the pains they got during the infection, they were refraining from having another total hip or another hip surgery done. I have done revision after girdle stone, 3 years after girdle stone, for a patient which I could convince that it's better to have a good hip, and she was in the early 40s of her life. So consider that this is a kind of good temporary situation. It's much better than girdle stone situation, and I think that time maybe in favor of the bone quality. It can improve better than that in due time, and let us hope that this patient can stay with this hip for a good time. All what I may ask Professor Ayman for this is that try to get a good hold on the patient, that she must come to you in 6 months' time, intervals, for example, to make sure that he's building up bone, and to pick up the proper time for doing the surgery.
Possibly by the time of revision, you can put a cementless system.
I've stressed, yes, at least yes, possibly yes. I've stressed this on the parents and the girl herself, and she's coming regularly. I think she's due for the second year review. But when she came after a year, and in this situation, I didn't like to revise it that early, especially that she's enjoying Femur. She's hopefully coming soon to be reviewed, and once I feel that there is loosening of these implants, I will revise, even if it is with very little symptoms. In fact, to be quite honest, as a general trend, I like to pick these patients for revision early than late. Once I see some resorption of bone or bone cysts, or early loosening even of a part of a component, I prefer to intervene early than late, because leaving these patients with little symptoms or minimal symptoms, usually they come back, as Tariq says, with a disastrous situation and bone resorption and industrial cavitation. So yes, picking them early is far more better, obviously.
Okay.
Ayman, do you expect your revision procedure for these patients to be through an endofemoral approach, or do you think you might need to resort to an ETO?
Well, as far as I can see from these X-rays, I have very little cement mantle to worry about removing. And I know beforehand, when I'm inserting this, that I haven't pressurized the bone cement by any means. You have seen it already when I'm presenting the video. It was a kind of cement that's covering the surface. There is no cement distal to the tip of the stem, and the cement hasn't penetrated. There is no anchor holes on the acetabular side. So I think once these cemented cups are being removed, I think I will go for a cementless standard length procedure.
Okay, because just to cut my comment, I don't want to lengthen this discussion. Yes, on the acetabular side, there wouldn't be a problem, but I have come across a lot of surprises of cement mantles that looks pretty much like that, whereby trying to remove some cement inside, you could not do it, and then you find that you're violating the cortex, in which case then you might need to do some kind of a TO, or trochanteric osteotomy. It doesn't have to be the extended trochanteric osteotomy.
Yeah,
in which case then you need to put a longer stem in a younger age group, and I think this is probably what was concerning Dr. Tariq when he didn't want to violate the femur as well. Thank you.
Thank you, Fred.
Okay, dokie.
Okay, shall we move to the next case?
Yeah. Okay.
Or shall I stop at this stage if you like?
Professor Ayman Suleiman, do we have time for another case?
I think we can take a case from Dr. Bakouri first, and if there is another time, we can ask Professor Abed to do the second case.
Okay, thank you very much.
Thank you, Professor Ayman, for this nice presentation.
Thank you very much.
Abed, a very illustrative case. I think we had a lot of discussion about sometimes these pathological fractures and these fractured neck of femur in diseased bone, even in younger age group, and the risk of infection. So if I may ask Ahmed Al-Bakouri to present his case.
شكرا دكتور أيمن.
And in the meanwhile, can Professor Abed answer some of the questions in the chat room?
There for the hospital.
Thank you very much, everyone. I'll just go through things so quickly because of short of time. So I'm not going to talk about the introduction and all that probably. We'll go straight to the case presentation. So just a couple of cases, very quick, very hopefully straightforward ones. Just to let everyone familiar with the trauma management in the UK management system. So we receive all the neck of femur fracture go to the trauma units, and trauma units, we have more than 174 something trauma units in the UK. Then most of the neck of femur fracture will be treated in the trauma unit. However, the complex ones or associated with other polytrauma injuries like multiple injured patients will be transferred to the trauma center. So when we receive patients in here in Plymouth, southwest of England, we receive patients from North Devon, from Exeter, from Torbay, and from Cornwall Hospital. First patient is 47 years old male with a history of epilepsy, had a fit in October 2019 and had a fall, transferred initially to Exeter in the UK, which is about an hour drive. His right leg was externally rotated, shortened, sciatic nerve is intact, and he has this X-ray with displaced neck of femur fracture on the right hand side. As we probably all can see, hopefully the X-ray hopefully will be obvious on the screen, but the neck of femur is displaced and is broken, is comminuted. There is also fracture of the acetabulum, you can see there as well. So he had a CT scan. Oops, sorry, it's not, I think the video is not working, sorry, but it is essentially is a posterior wall and column fracture with the dome impaction. I mean, the options probably are limited for this patient, but I would like to ask everyone if what their preferred option to treat this patient is. 47, history of epilepsy, and with this problem.
It's 8 o'clock already.
Yeah, I know. Sorry.
It's 8 o'clock already.
دكتور فؤاد موجود معانا؟
ايوه.
اتفضل يا بيه حضرتك اول.
Can you see the screen?
Yes, we see the
Yes,
screen.
we can see the screen, Ahmed. We can see the screen.
ايه رايك حضرتك؟
If he was a non-epileptic and with this type of fracture, I would probably proceed with fixation of all the fractures, the posterior wall, as well as the femoral neck fracture. So considering this type of fracture, I would probably proceed and fix the posterior wall first, reduce it and fix it, and then I would proceed and try to reduce the femoral neck fracture. Well, depending on how things will proceed, whether I would go for an open reduction of the femoral neck, and that is something that this is one of the types of combined injuries where I would resort to flip osteotomy, which would allow me to open the capsules from the front and reduce the fracture anatomically, and then I'll fix it with 3 cancellous screws. But considering the epileptic issue in the fracture and whether or not I would consider an arthroplasty, if I were to decide for an arthroplasty, I would again fix the acetabulum as per standard procedure, and then I would replace the hip immediately with a cementless cup and cementless stem as well. So a cementless system with fixation of the posterior wall and acute primary replacement of this fracture.
Okay, fantastic. A question for Dr. Fouad. So if you have a posterior column, posterior wall, and margin impaction and dome impaction and neck or femur fracture in non-epileptic patient, would you rather fix it as well, 47?
Yeah. 47, I would definitely fix it. I would go for doing the whole job. I would elevate the impaction, whether it's a dome. You know, this is not the true anteromedial sort of dome that comes with the elderly patients with an anterior column. These are the types of dome fractures which are posterior and posterior superior. And the literature has talked a lot about the negative confounding variable in terms of margin impaction with the end result, and there have been lots of debates about it. And I tend to believe that a well-elevated and grafted margin impaction does not increase the negative results of a posterior wall fracture. So if you elevate margin impaction, you graft it, you fix it, and then you reduce anatomically the posterior wall, you're probably having a comparable result with any standard posterior wall. So to answer the issue about whether there is a margin impaction, whether on the posterior side or on the dome side. Regarding the neck of femur for a 47 non-epileptic patient, I would probably go for an open reduction and fixation. And as I said earlier, I would resort with a trochanteric flip that gives me an anterior access to the anterior wall, to the anterior neck, and I would reduce it anatomically and fix it with screws. That would be my standard practice.
Yeah, thank you very much.
May I
yeah, of course.
add something? Yes, I totally agree about the plan from my professor, great educator, Dr. Fouad. What is the difference that I can do is maybe the approach wise, and the ordering of the fixation. I may prefer to go for the femur fracture first, the proximal femur, the neck femur fracture first. I'm not sure about how we utilize the flip osteotomy in acute femoral neck fractures in concern of the vascularity of the femoral head, how to preserve the vascularity while the fracture is displaced, and when you do the flip or you do some preliminary fixation by pins to have a safe dislocation, then you revise the reduction after you safely dislocate the hip with the head neck part as one unit. Can you elaborate more?
Yes. Well, actually, Abdullah, the flip does not mean surgical dislocation. The flip is a flip. The flip is the approach. And the reason why I would do a flip osteotomy is that with a flip, you get a perfect access not only to the femoral neck, but you also get a perfect access to the femoral head. Yes. And that's very important. In fact, this is my standard procedure when you have an acetabular fracture associated with a femoral head fracture. Yes. I do exactly the same. Yes. I would reduce the acetabulum, fix it anatomically, and then without opening the posterior capsule, I don't like to explore and elaborate on the intra-articular space from the posterior approach, from the posterior capsular rent. I don't like to play with that at all. So I'll just basically do a clean trochanteric flip osteotomy. I would go with an anterior capsulotomy. The anterior capsulotomy allows me to reduce even a femoral head fracture. So if it does allow me to reduce a femoral head fracture, it's much easier to reduce. No dislocation. Why do you want to dislocate it? So basically, the only thing that you will do is that you will do a flap capsulotomy that will give you a perfect access into the base of the femoral neck. That will give you an excellent access to reduce the neck, the same way with the beautiful pictures you showed in your very nice lecture earlier on. Putting a clamp, pointed reduction forceps, reducing the neck anatomically, then then putting 3 screws across the femoral neck, reducing this anatomically and fix them rigidly, and then you would reduce the acetabular fracture. I don't think that the presence of an associated femoral neck fracture would tend to let me choose an arthroplasty unless there are further negative confounding variables that would let me drop the fixation for the femoral neck fracture. And I know that Dr. Bakouri very nicely pointed the impaction, but I'm one of the people who do not believe that the margin impaction is a negative confounding variable when they are properly reduced and fixed. And I think that even Joel Matta would belong to this group of people who has shown also with his evidence that the margin impaction is not a negative confounding variable with the result of the posterior wall fracture.
Are you going to explore the doom impaction posteriorly, Fuad, by doing a capsulotomy posteriorly?
No, most of these cases you don't really need to do that, Tariq, because as I'm sure that you know very well, when the femoral head tends to dislocate, which in this case probably didn't go into a full dislocation because of the femoral neck fracture, but if you also didn't have a femoral neck fracture and you had a frank femoral head dislocation, you know that the femoral head dislocation tend to dislocate through one of two pathways. Either it goes through a rent of the capsule or it goes to the fracture plane. And if you have a margin impaction, usually the femoral head has gone through the fracture plane. So this means that if you elevate the wall, obviously preserving the soft tissue attachment, and you open it like an open book, as we tend to always tell in our lectures, you will find a very good access to any kind of margin impaction, whether it's in the dome, superior, posterior, irrespective, you can actually get an access to that. And in fact, if you have a very anteriorly displaced dome margin impaction, you can also use a flip osteotomy, but in a different manner now. It's a flip osteotomy that will go from back to front rather than from front to back. For a femoral neck fracture fixation, the flip osteotomy would go from front to back, but for a femoral, for a flip osteotomy that allows you a marginal exploration, you will just simply elevate the trochanter anterior and superior, and that would give you a perfect access into the dome impaction that you can reduce in place and graft from the back.
Okay, thank you.
I agree with Dr. Fred. Actually, it's just for, we use flip osteotomy for access. Lots of the time for marginal impaction, for dome impaction, it's great for access. So you don't have to dislocate the head. You just use it for access, and it gives you a very good view. That's fantastic. For this gentleman, we know that the options are definitely fixation of the acetabulum and fixation of the femur. The problem here is his femoral neck is comminuted. We discussed with him the options, both options, whether fix acetabulum and neck versus arthroplasty, and he has epilepsy, and he elected for hip replacement. So what we did for him is we did fix and replace all from the back with hybrid. So did a hybrid hip extra stem dual mobility socket and highly porous shell with fixation of the posterior column with the plate fix and replace, use the femoral head as the bone graft. And this is his 1 year x-ray follow-up, and he's doing well. He's back to work. And he's doing his day-to-day activities. Hopefully he will this will serve him well.
Ahmad, sorry, what was the buried surface?
It's metal dual mobility socket. So it's MDM striker titanium cup.
Ahmad, please, if you can elaborate more in this type of cups, because we have some prototypes here in Egypt that you have the shell with cementless, and you could put multiple screws in. You put a metal liner, and then you put the bipolar head. Is this the way? Because the track record of this kind of metal backed shell with a liner, does it have long track records, or this is just new for the market?
Yeah, it's definitely newer. So for dual mobility, the old French school for dual mobility is the monoblock dual mobility sockets, which has probably now, I don't know, probably more than 20 years or longer in the track record. So it's well proven and it's very good. The newer thing, this is like by Stryker, and also Biomet has a similar one, which is G7 cup. You can use either titanium socket or G7 socket from Biomet. You put it in. It's the good thing is highly porous socket. It's similar to the Continuum cup with Zimmer. Probably less friction, slightly less friction. And you have multi-hole cup. You can put all screws everywhere. So it's a rigid shell. Once you're done with that, you can put a metal liner in. So it's modular. And then you can use your polyethylene and ceramic head on the trunnion of the exostem. So it's really good in when you have problems with bone stock, because you can actually use it on with the augment, with buttress. You put multiple screws everywhere, but maybe we're not sure yet, but maybe the stability is not as stable as the monoblock, because I think you have the hemispherical cup and you put a liner in, that's probably reduces slightly the depth of the socket. So this why probably maybe the stability probably is less than the French ones, and also the track record is slightly short. It's about probably 7 years now, but it's a good results in 7 years.
Ahmed,
thank you.
Can I give a comment on this, please?
Of course, of course.
I think that this patient has lost the chance to have his femoral neck and the head still in. Epilepsy is not an absolute indication to change the situation from internal fixation into total hip straight away. The chance of healing is good, and the patient should be under control of by anti-epileptic treatment.
Of course.
And in the cases which I dealt with, when we have combined fracture of the acetabulum together with fracture of the neck of the femur, the chance of healing of the neck of the femur is better than the cases of fractured neck of femur per se, simply because of the absorption of the thrust and conversion of the high velocity injury into low velocity injury, giving the patient a chance. So if I were in your place, I should have thought about internal fixation of the shaft. And I differ with Professor Fouad in the chronological situation, because fixation of the neck of the femur can be done first. And consequently, you can apply some movements with the hip, which will allow you to go inside the fracture site of the acetabulum and to repair the impaction points by reduction and grafting on top. All what the patient is going to lose is something like 3 months of non-weight bearing time, during which both fractures may heal, and he may earn a good or normal hip. He is 47, and he should have been convinced that he deserves to have this trial. I don't say that what has been done was agreed upon during counseling the patient between you and himself, and this is fair enough that he can choose it, and then you can do it for him. But still, I feel that he may be having some kind of chance with reconstructive hip surgery.
Absolutely, of course. So that's what we told him initially. So if you have this, you'll be off work for 3 to 6 months with fixation till you go back to work. If you have this, this is the advantages. These are the disadvantages, and he was convinced to have hip replacement. Unfortunately, this is how it works here, and the patient has to choose. Unfortunately, but, yeah, absolutely right, Professor. Thank you. Yes.
Very illustrative case, Mr. Bakouri. Just can you tell me why did you choose fixation of the stem by cement here?
Yeah.
You don't.
Yeah. It's I know it's debatable, but with neck of femur fracture, although he's young, we prefer to use cemented stems. It's really
This is
debatable.
the extra
Yeah.
influence upon.
Yeah, I think most of the UK now, if you have a young patient with neck of femur fracture, they tend if it's not high energy trauma, if it's low energy trauma, they tend to use cemented stems.
Okay, so can I ask Professor Ayman Abeid to present his second case?
Oh yeah, absolutely, no
Yeah.
Yeah, that's fine. I'll just.
Do we still have time for a second case?
I think we can squeeze a case in the next 5 minutes.
Yeah.
Okay.
Sorry, I'll stop sharing.
Okay. Thank you, Mr. Bakouri. Nice to hear from you.
Thank you very much.
Give me a second. Okay. Can you see that?
Yes.
This is a different story for a 34-year-old manual worker, had a tibial plateau fracture and a missed fracture neck of the femur. This is now 4 months down the line. You can see the proximal migration. You can see the fracture line and the head quality and the bone quality. Perhaps it's open now for debate. What should we do? Should we fix? Should we replace? 34, manual worker.
So if I can answer this, in this age, we try to preserve the joint as much as we can. So I would go for fixation.
Okay.
Even with the elegance for 4 months and all of these problems.
Okay. I
will do
arthroplasty.
May I add, if you do fixation, you do osteotomy or not?
I would, if there is, you mean medialization osteotomy?
Valgus.
Osteotomy. Well, I think a valgus osteotomy will improve the shape of this fracture and it will add to union. So it is more complicated, but it will increase the chances of success, I think.
May I add something, Professor Ayman?
Please, yes.
Yes, I will ask for further investigation, actually. I will do a CT scan and the MRI. The MRI will give me some idea about the vascularity of the head, might be, because this is 4 months down the line. And the CT scan will show me the remnant of the head, of the neck, because what I can see here from the X-ray that the neck is resorbed. I'm not sure, is it resorbed or just rotated, and I cannot see the margins of the neck. So I will do some further investigation first before reaching a decision.
Okay.
Yes, Dr. Ayman, if it is possible, as Professor Tariq said, we can't judge on this X-ray. You should do this X-ray. You should do traction and medial rotation to some degree to can judge for the neck, the quality of the fracture or resorption or something. because much of the neck is covered by the greater trochanter, and so you need to do traction view with traction of the rim and some medial rotation about 15 degrees or something, so you can judge better than this X-ray.
I fully agree. The only thing is that I'm retrieving this case from all the files. It was 10 years before, so I can't show you the CT, despite the fact that I had a CT at this stage.
But you can tell us what was in the CT at least.
What was in the CT is that the head is intact, as you can see, but the neck is shortened with some resorption at the base of the neck. So what you can see now on the X-ray is almost showing you how much is left from this neck. Yes, there was resorption of the neck. What you can see is what is real.
Practically speaking, Dr. Ayman, I think most of the practice here in Egypt will go for hip replacement, straightforward.
Please, Dr. Ayman, can we ask for please, Dr. Ayman.
أنا معاك، اتفضل حضرتك.
لا ليه نقول ان البراكتس على طول هيب ريبليسمنت؟ يعني ده حرام يا اخوانا. لا يعني اذا كانت الناس بتستسهل الهيب ريبليسمنت في بلدنا، ولان في ناس فعلا الهيب ريبليسمنت عمليه سهله، كلنا عارفين انها عمليه سهله. اللي صعب هنا هو
يس دكتور حازم،
ايه اللي ان فيفر للبيشنت اللي عنده 34 سنه ده
ومانيوال وركر.
انا ما بقولش حاجه، انا بقول انه هيب ريبليسمنت از ا جود سيرجري، وانا ام سيرجن فور هيب ريبليسمنت. انا من اول اللي ابتدوا يعملوا هيب ريبليسمنت في مصر. ام نوت ديناينج ذا فاليو اوف هيب ريبليسمنت، لكن انا ديناينج الكلمه بتاعت انه كومن براكتس هير. اول ما تشوف دي تقول انا هعمل له هيب ريبليسمنت. وعلى فكره
للاسف
الهيب ريبليسمنت كانوا بيعملوا اللي زي دي اوستن مور ويوني بولر اللي هي مونو بلوك which was a disaster for young patients.
للاسف يا بيه والله.
معلش احنا we got to think for انا كنت ساعات في ميتنجز ريكونستراكتيف اقول اللي هيقول هيب ريبليسمنت يقعد ورا او يخرج، لانه هنا احنا we are looking for conservative hip surgery if possible and is going to give a good result. واذا كنا بنتكلم على ان الحالات دي لازم يعملها حد اكسبيرت، فاحنا بنتكلم بقى على اللي قدامنا دي اللي ممكن ندور على حد اكسبيرت to try to reconstruct ده.
دكتور طارق،
يعني انا سوري ان انا اتكلمت.
دكتور حازم، يعني
دكتور طارق.
ايوه بيه.
I should ask for MRI to look for the viability of the femoral head, and I think this patient needs to be reconstructed by any methods, plating, screwing, bone grafting, something like that. But MRI is mandatory in this case to judge the condition of or the viability of the femoral head before, as Professor Hazim said, not every case do hip replacement.
انا معاك يا دكتور محمود بيه، بس يعني الفكره بص انا هقول لحضرتك بمنتهى الامان، هو اوريدي ميسد فراكشر. هو دايما الميسد فراكشرز لما يبقى عيان عنده ابسيلاترال شافت او ني انجري دايما بتبقى نون ديسبليسد فراكشرز انيشيالي، وعشان كده ما بتبقاش تعب العيان قوي، ما بيشتكيش منها قوي، وتيبيال بلاتو فراكشر بيتعالج منه، فخلاص يعني الماجوريتي من دولت ما بتبقاش ديسبليسد فراكشرز. وده يمكن السبب ان برضو الماجوريتي منهم ما بيبقاش عندهم، ما يحصلهمش اف ان. لو العيان ده عنده هاي انرجي تروما، كان بعد 4 شهور كنت شفت الهيد حته ثانيه خالص. انا معاك الهيد فايبل. يعني السي تي انا معاك ان السي تي هيورينا اكتر بالنسبه للبيز اوف ذا نيك وهاو ماتش ريزوربشن هاز هابند. والام ار صح ان احنا نعمل ام ار عشان نبقى متاكدين من الفايبيليتي، بس ان جنرال باي فار العيانين اللي عندهم نون ديسبليسد فراكشر دولت ما يحصل لهمش اي في ان ايزلي. يعني
هو لو في حاجه دكتور ايمن اعتقد انه انا طبعا هضم صوتي للصوت ده دكتور حازم بيه، انه we should always strive at reconstructing a hip at this age. يعني a patient at the age of 30
ماشي
34, as much as we can, we should need to preserve the hip. The only difficulty, and at least in my head, I faced particularly difficult to oh, okay. Can I continue? Sorry. Yes, the only thing that I would the only thing I would quickly say is that the resorption of the femoral neck is usually a very difficult challenge to fix. If you don't have a lot of resorption of the femoral neck, then definitely one should strive to reconstruct these hips very well. And even with a bit of resorption of the femoral neck as well, another secondary later procedure of femoral neck osteotomy can be added later on. But if you obtain a union at the femoral neck with preservation of the vascularity of the femoral head, even with resorption of the femoral neck, you can sometimes resort to other secondary reconstructive procedures such as a neck lengthening osteotomy. And we've done some of these and they work very well. I would still consider that if you can obtain union with a vascular femoral head, that would definitely be better than any hip replacement at this age group.
I'll listen to what you say, Fred. I'll do what you said. انا موافق تماما مع وجهة النظر بتاعت ان في شاب عنده 32 سنة وحضراتكم قلتوا دوت. I can understand الورز بتاعت طارق الخضراوي. انما في السوشيال كلاس دوت لو احنا قدرنا فعلا ان احنا نديله نورمال هيب وقدرنا ان احنا اتشيف يونيون، بالتالي هيبقى افضل له ان انت تبريزيرف ذيس نورمال هيب فور سام تايم. عشان كده انا حابب ان انا اوريكم، مش عارف الصور ديت سي ارم ايمجز قديمه يعني، فاعذروني لو الكواليتي بتاعتها مش حلوه قوي. انما انا ستارتد بان انا احطه في تراكشن شويه وان انا الاين واير going centrally into the head. حطيت بعد كده anti-rotational screw superior to the guide of the DHS, and I assured the position of this in both AB and lateral. بعد كده عملت الاوستيوتومي at the subtrochanteric level aligned to create a better biomechanical milieu for this fracture to heal. This is the side plate of the DHS having adjusted the neck shaft angle. And this is the immediate post-operative X-ray with a valgus position or valgus reduction. The contact anteriorly is not bad, with bone graft being placed anteriorly. At 4 months, I observed that the anti-rotational screw is perhaps leaving its place and trying to get into the hip. So I removed it, and at 1 year, this was the X-ray. Shortening of the neck, yes, but we have preserved this hip. He's fine. He's now 10 years down the line from what I'm presenting now, and he's still living with this hip, quite happy doing his job as a manual worker.
Thank you.
Yeah, thank you for your effort. You have given him reasonable hip to work. It's not perfect, definitely, but it is reasonable for a manual worker. But my question is, or my worry is, if that hip has failed early, after a year or so, in the form of collapse of the head or whatever, the osteotomy usually makes the total hip replacement more difficult, and the results is less predictable. This is my worry. So sometimes we see a patient of 35 or 36 in a situation like this, and we need to put for him a total hip replacement, and the circumstances is less favorable rather than going in a virgin femur. This is my worry. But if you give him 15 years or 20 years good hip, definitely chapeau.
انا I take your point والله يا طارق، بس شايف احنا في الاوستيوتومي اللي احنا عملناه ما عملناش ديفورماتي في البروكسيمال فيمر تخلينا نستراجل في ان احنا نحط ستريت ستيم. التروكانتر از لاتراليزد، فالانتري بوينت بتاعك برضو هيبقى ستريت انتو ذا مدلري كانال. I take your point والله. بس في احيان كتيره والواحد كان زمان يمكن انثوسياستيك شويه ان هو تريكونستراكت وكده، كان بيعمل الحاجات دي. مش عارف لسه هعمل ده لو جالي دلوقتي ولا لا، ما اضحكش عليك يعني.
لا طبعا تعمل، انا رايي انك تعمل ده. This is absolutely طبعا this is a very good. انا عايز اقول لك على حاجه دكتور ايمن.
معاك يا دكتور حازم باشا والله معاك.
يمكن لو ترجع بالسلايدز كده للبوست اوبراتيف immediately لو سمحت. ايوه، لو انت كنت مليت الجاب دي ببون جرافت كورتيكو كانسيلس جرافت and you impacted it، هي it seems ان انت لما عملتها يعني زي ما تقول ايه، انت قلت كده كفايه. لكن if you are going to do it again please fill the space اللي هي عند الكالكر فيمورال a good strut of bone graft. لو عملت كده you are going to maintain the length of the neck عند الوضع اللي احنا فيه and the medial support will prevent the varus deformation او the varus deformation of the neck shaft angle اللي موجوده. ف it would have been the result would have been better than that. Nevertheless برغم الكولابس اللي حصل the result is good and the vascularity of the head is still there. نيجي لنقطه application of total hip in cases of subtrochanteric osteotomy. I believe يا دكتور طارق انها technically it's not difficult at the moment لما بنعمل الستريت هيبس، لانه you aim at the medullary canal and you do not work considering the position of the trochanter where it is. وعملنا يعني في سيريز من هذا الكلام total hip replacement after displayed subtrochanteric osteotomies and يعني difficulties have been overcome.
هي definitely يا دكتور حازم بيه، انا ما قلتش انها ما تتعملش، انا بقول ان هي لا مش موضوع برضك اصعب. results of total hip after proximal femoral osteotomy, the results are less predictable than when you do it in a version femur. Definitely. ما فيش حد يقدر to challenge this statement. longevity doubtful. ما هياش زي برايمري توتال هيب ريبليسمنت definitely. فهو ده هو ده ماي وري انا. لكن بقول للايمن ان هو لو انت عملت ده وادى العيان 20 years hip till the time of hip replacement very good, but my worry is ان هو after a few months or 1 year الهيب ده will fail and he will need a total hip replacement.
For sure he may need total hip replacement one day possible، يعني مش for sure قوي
طبعا يعني possible.
برضو عايز اقول لك حاجه يا دكتور ايمن، انا رايي انك انت يريموف اذا كان البيشنت لسه accessible يريموف ذا امبلانتس ناو.
هو بيتابع مع حد من الرجاله بتوعي يعني في مكان ما كده يعني. up until now هو كويس.
We can remove the implants and pack the track of the DHS screw with bone graft. You will give him another chance for more longevity.
طب ليه يا دكتور حازم؟
انا متشكر.
ليه لانه
مفيش هيلينج، مفيش يونيون لغايه دلوقتي؟
لا اتس يونايتد
10 سنين يونايتد طبعا.
لا اتس يونايتد.
طب امال ايه فايده الجرافت بقى؟
It's not completely united but it has united. Application of bone graft is going to improve the of the circulation in the head and it will give some longevity of the head.
اوكي
يا باشا ربنا ما يحرمناش من حضرتك.
Well done.
Thank you very much Professor our Professor حازم عبد العظيم، دكتور محمود مبروك، all the
عايزكم تعملوا سكرين شوت للصوره دي دلوقتي.
الصورة دي
then you keep it
طب
for
ثانية
later.
واحدة.
ايوه
ايوه عبد الله طلع اهو كمان.
دكتور فؤاد دكتور استنى دكتور فؤاد بس دكتور فؤاد دكتور فؤاد
افتح الفيديو يا باشا.
ايوه
أيوة
دكتور
باشا.
فؤاد أهو.
يا فؤاد
انا عجباني
هنا
اكتر
فؤاد.
حاجه
معاكم.
الباك جراوند بتاع الدكتور فؤاد دي هي احلى
لا لا،
حاجة
بص انا اتسالت على الباك جراوند كتير قوي يا دكتور احمد، وده سر من اسرار المهنه، مش هقوله لحد، بوليسيه خاصه كده عنه.
صوتك قطع على فكره.
عشان اللقاءات التلفزيونية يا دكتور أحمد.
اصله بيه قاعد على الكوبري فصوته بيقطع.
الدكتور فؤاد ما عندوش
عشان
شبكه
اللقاءات
كلكم محبوسين
التلفزيونية.
كلكم من الكورونا، عشان انتوا كلكم محبوسين من الكورونا، وانا قاعد على الكوبري
قاعد على الكوبري.
قاعد في الستيت.
تحقدوا
قاعد في
عليا
الستيت.
ده.
دكتور فؤاد قاعد في
سعيد
الستيتس
والله خالص
لوحده
بان
كده
انا اكون معاكم ليلاد يعني. اتعلمت كتير يعني من
كان يوم جميل يا بيه والله.
والله
تشكر
ده احنا اللي
دكتور أيمن،
اتعلمنا
كانت
منكم
حلقات قوية جدا.
شاكرين جماعة.
نشكر الدكتور ايمن سليمان، شكرا دكتور حازم وريسنا، شاكرين.
والله
شكرا جزيلا.
طيبين.
سعداء بيكم.
وإن شاء الله يكون
شكرا جزيلا.
الاتنديز
تصبحوا
تستفادوا،
على خير.
والف
ان
شكر.
شاء
انت من
الله.
اهل الخير.
تصبحوا على خير.
شكرا
تمام.
جزيلا جميعا، وكانت ميتنج جميل وكلنا استفدنا جدا.
شاكرين جدا.
شكرا.
Thank you
وانت
everybody.
مع السلامه.
شكرا، مع السلامه.
معلش يا مريم.
ازيك يا حازم؟
دكتور طارق، مساء الجمال.
انت وحشني.
Really
مش عارف
sorry
هو-
couldn't join from the beginning I had to go in and out multiple times.
معلش احنا
هو
كان
لسه
في شوية
احنا
لخبطة
لسه على الهوا ولا ايه؟
اعتقد لسه مع الاودينس يعني.
طيب
لسه.
اوكي.
طب بلاش كلام بقى خارج.
خير ان شاء الله. شاكرين جدا والله.
لا بس والله ان استمتعنا بيكم ووحشتونا وانتوا ايه اخبار الدنيا عندكم؟ طمنونا.
والله الحمد لله لسه عايشين يا دكتور طارق.
الحمد لله رب العالمين. على اللي انتوا بتدوا فاكسينز، احنا لغايه دلوقتي لسه ما خدناش حاجه.
ليه بيقولوا في خلال 30 سنة مصر هتخلص
على 2060
عبد الله
ان شاء
بيسألني
الله.
هتاخد الفاكسين ولا قلت له هاخده، فبيقول لي
لما يجي.
هتاخد انه نوع، قلت له اي حاجه موجوده.
ليه مش
ما
بدأوا
عندناش
يدوه في
أنواع
القسم صح؟ مش لسه بادئين يدوه في الكلية بقى؟
لسه النهارده سمعت ان بوريس جونسون اخذ استرازينيكا النهارده.
ايوه لازم
هيبقى كويس. اصل
والله
ده 20 مليون واحد خدوه يا دكتور.
كانت المانيا وما اعرفش وايطاليا وبتاع وقفوا ان هم ياخدوه، بعدين رجعوا تاني ابروفد ان هو ممكن يتاخد. فالنهارده بوريس جونسون اخذ استرازينيكا عشان يقول لهم يعني ان انا هو اخدته ومفيش مشكله يعني.
اصل الانسيدنس بتاع الكلوتس ده اقل من الانسيدنس في النورمال بوبيوليشن.
هي دي الجزء السياسي منه على فكرة ورا الموضوع ده.
طبعا عشان البريكسيت انت يعني تطلع وبعدين تعمل لي فاكسين وتديهولي كمان.
متغاظين جامد هم عشان ما عندهمش دوزس. المانيا والاتحاد الاوروبي ما عندهمش انف دوزس، فمتغاظين جامد فعايزين يضربوا استرازينيكا.
احنا سمعنا ان احنا هنجيب هنا استرازينيكا برضه.
والصيني ده كويس للناس
والصيني
اللي
كويس على
صحتها
فكرة.
كويسه.
الصيني كيلد فيروس يعني.
صحته كويسه بس
لا،
يعني
احنا
يبقاش
هنعمل
عنده
حاجة
uncontrolled
مختلفة عن
hypertension
العالم
او
كله.
diabetes.
احنا هنعمل حاجه مختلفه عن العالم كله، خلي بالك. ناخد 2 دوزز، واحد صيني وواحد استرازينيكا. حقيقي.
انت عارف ان هو كان في توكس اللي هو combination of two types of vaccines، بس كانوا بيتكلموا على اللي هو الار ان اي واللي هو زي بتاع فايزر مع حاجه زي اللي هي استرازينيكا اللي هو ليف اتنويتد. كانوا بيتكلموا على الكومبينيشن من ده، بس طبعا ما فيش ريزلتس حد يقدر يقول.
مفيش اي حاجه خالص.
في ستادي شغاله دلوقتي على 2 فاكسين.
ده الموضوع الاسود ده.
احنا الكومبينيشن بتاعتنا.
اتفضل يا دكتور سوري.
لا بقول لك احنا الكومبينيشن اللي عندنا ممكن تحصل نتيجه الشورتج. يعني انت اخدت استرازينيكا مثلا، لما جيت تاخد الدوز الثانيه ما فيش استرازينيكا.
ما هي كده في كل العالم.
ممكن تاخد باي حاجه.
احنا عندنا كده. هم بيعملوا الستادي دي ازاي عشان لو ما عندهمش دوز من اللي انت خدته بعد كده تاخد دوز ثاني.
ما هي دي
في العالم
كنت
كله يعني شورتج الفاكسين مش قليل في كل العالم يعني مش
لا، موضوع
بتقول يا
استرازينيكا
حازم
ده اساسا اثر على بعض العيانين هنا. انا في واحده عيانه بعتت لي جواب لذيذ قوي من يومين، تقول لي انا مستنياك تعمل لي الني ريبليسمنت بتاعتي، بس اللي معطلني الفاكسين. انا خدت استرازينيكا الفيرست دوز، ودلوقتي انا شايفه ان هو يعني doesn't show good results in my age group، وانا عايزاك تتصرف لي واخد الفايزر.
هو انت اللي عندك الفاكسين؟
انا حطه في الثلاجه اصلا. انا
طلع من اللي جوه اللي مخبيه مستر حسني عندك
مستر حسني مخبي
مخبي
الفاكسين
الفايزر في
عندك
الثلاجه.
هو لو عندك حاجه طلعها لنا كده.
عينيا والله ما تاخرش عليك يا دكتور ايمن.
انا خدت السكند دوز من يومين، امبارح والنهارده والله يا دكتور ايمن مطحون وانا بعمل برزنتيشن، ومحضر 4 حالات مش قلت واحده.
انا حسيت بكده صدقني.
انت خدت الفايزر؟
فايزر.
طب فايزر كويس. فايزر كويس.
فايزر ده خلي بالك معناها ان انت كل المعلومات اللي في دماغك عندهم دلوقتي في CIA
كلها
عند الدكتور
في
بيل جيتس
في الشيب.
انا بقول لك عند الدكتور بيل جيتس دلوقتي.
كله
يا عالم والله يا عالم هنتسخط حاجه ثانيه قريب.
لا، وكل الباسورد بتاعت البنك بتاعتك مع بيل جيتس في جيبه دلوقتي.
طب ممكن نبدل، هو ياخد بتاعته وانا اخد بتاعتي خلاص. ما عنديش مشكله، انا ممكن اسيبها لاي حد الباسورد بتاع البنك ده.
هو سؤال صغير بس يمكن عشان الواحد فاته كتير في العلم، هو ار وي نوت يعني pushing the limits شويه في الريكونستراكشن في الحالات اللي هي يعني
ايوه
يعني
انا ما انا قلت
انا مش
لأيمن على
انا
الحاجة. يعني انت دلوقتي عملت اوسيوتومي في حاله بقى لها 4 شهور، الريزلتس دلوقتي بعد 10 سنين، هو احنا شفنا اشعه بعد سنه. الو
ايوه
لا
شفنا اشعه بعد سنه، والاشعه اللي بعد سنه دي باين ان الهيب ديفورمت، حتى الهيد نفسها باين انها فلات. بس طب انا دلوقتي لو انا عملت توتال هيب بعد سنه ولا سنتين وبعد ما غيرت الاناتومي اوف ذا بروكسيمال فيمر، ما استفدتش حاجه.
صحيح.
برضك الحاله اللي هي كانت بتاعه اللي هي الكيوي هيب، ما انا برضك قلت ماي وورز، هي بقى لها سنه على ويل تشير، كانت هتفرق ان هي سنه وشهرين؟ ما كانتش هتفرق انها لو قعدت سنه وشهرين، وبعد كده كنت اديتها بروبر هيب ريبليسمنت.
هي
كنا هنعمل زي ما حضرتك عملته بالظبط
100%. كان يعني العيان ده لو مثلا عندنا في الام دي تي 100%
هنعمل له بس
staged operation،
ونعمل له
100% هتبقى يعني اصل حته شويه elevation in the inflammatory markers يعني اتس كلو فور انفكشن. يعني هو احنا بنحطها عشان يعني هنتكلم على الانفكشن بعد كده. 100% هتبقى first stage removal of the metal والهيد وتيك سامبلز، وممكن تحط زي ما قلت كده بالظبط يا دكتور طارق بول اوف سيمنت ان ذا استابلم، واستنى الريزلتس، لان انت ممكن if you want to go for a second stage هتحتاج تعرف الباج ايه هو، ممكن تحط انتيبيوتكس ان سيمنت، حاجات كتيره. انما وبعدين leaving the patient for long هترجع بس periprosthetic fracture.
يعني بالظبط كده. ما هي المشكله ايه؟ ان هي بين فري، وبعد كده هتبص تلاقي هتبدا تديفلوب بين، وبعد اول ما بتديفلوب طبعا جرادوال بين، هتبص تلاقي بين قليل. البنت طبعا مع الاكسبيرينس بتاعت السنه اللي هي قاعده على ويل تشير، مش عاوزه تخش في another experience of surgery، هتبدا تاخد شويه مسكنات، طب النهارده رجليها تعبانه، طب ما اعرفش ايه ده، هتفاجئ بيها بقى لما هي بقت crippled by the severity of pain، وجايه لك وفيها periprosthetic fracture ولا severe bone loss ولا مش في بنت عندها 22 سنه ولا 21 سنه. طب ما انا كنت عملت لها اديتها شهرين على ويل تشير مور، وعملت لها بروبر هيب بعد كده.
صحيح.
يعني ده وجهة نظري ليه انا يعني ده. بس انت عارف سيرجري كان هوفمان دايما يقول لك ايه؟ يقول لك we are surgeons if you ask 3 surgeons about one question you'll get 5 answers. بالظبط كده.
بالظبط.
بص حضرتك دي مثلا، ده العياده شايف البتاع دي؟ ده كان جاي لنا من ترورو. حلو
أيوة.
bilateral معاه استابلم اكستندد بوسيول على الناحيه اليمين، ومعاه نيكو فيمر على الناحيه الشمال اليمين سوري كومينيوتد، ومعاه انترا كابسولار اكستنشن بس مش باينه في السي تي. فالمهم هم عملوا له بليد بليت وريدكشن كويس، بس زي ما حضرتك شايف البليد
من العهد
البليت انتير
العهد البائد يا دكتور ايمن.
ترورو دي كان عبد العليم فيها دي.
العهد
ومن ترورو ياتي كل جديد.
ترورو كل
عجيب والله ستيل من ترورو دول.
ولسه دارين فيرن هناك.
لا فول تايم برايفت شغال.
هو فول تايم برايفت بس. كمل احمد وبعدين احكي لك على حاله يعني على حاجه عملها
حالات
معايا.
انا عندي حالات كتير يعني عندي حالات كتير من ترورو. المهم
نورتون هناك مش كده؟
جالنا عملت له فيكسيشن للبوسيبل حل، قعد بقى كده اسبوعين، وبعد كده جاله ايه انفكشن في الناحيه اليمين.
الشمال اليمين.
وحطوا له بقى شويه اسمنت كده في التراك، وقعد بتاع 6 مظروف بس. فالمهم بس صراحه عملوها له كويس يعني في الاخر. عمل بليت تاني بقى، هو ماشي كويس لغايه دلوقتي. ده 6 شهور بعد البليت بليت والسنه ونص بعد الاستابل.
بس الانجل كويسه وبتاع
ولحم كويس ماشي كويس. بس فيعني ساعات برضه صح زي ما حضرتك بتقول، ساعات الريكونستراكشن بيبقى
اجريسيف.
هو بص
هي اجريسيف
to conserve the hip is a good idea.
بس
هي when it is when it can be conserved. انما لما انت بتستريتش انديكيشن، يعني انت حاطط في دماغك انا هكونسيرف يعني هكونسيرف. ايوه بس هو يعني ما ينفعش ان انا تو كونسيرف ذات تيب. يعني اتس بيتر يعني انا رايي ان هو كان حاط له جود برايمري. خلاص ايه المشكله؟ طب ما انت اهو حطيت ديول موبيليتي، والراجل اللي هو الابيليبتيك ده لو اتحط له جود ديول موبيليتي، طب ما هي خلاص. وحتى هو لو مانيوال وركر هيشتغل مانيوال وركر. ايه المشكله يعني؟
ده ماشي كويس جدا، مبسوط جدا.
ما انا بقول لك ما هيشتغل مانيوال وركر. ايه المشكله
يعني؟ هو مبسوط وانا مبسوط، بس هم اللي مش مبسوطين. مشكله والله، مشكله صعبه جدا. لا طب ده عنده نيك، لا مش قصدي، هو ممكن تعمل له فيكسيشن، انا مش بقول مش ممكن، وانا كلمته على الفيكسيشن، بس هو عنده نيك والدوم امباكشن. لما فتحته كانت الدوم متفشفشه خالص يعني. نيك امباكشن ودوم امباكشن وهيد امباكشن وبوستير مارجنال امباكشن وول والكولم. ده الول والكولم لوحده بيجي له اي في ان.
انا اللي عاوز بقى، انا كنت يعني اساله برضك. احنا دلوقتي هم الفؤاد قال الكلام ده كله على اساس ان هو ابيليبتيك. انا متفق مع حازم عبد العظيم
تماما. ده انا
ان
كنت
هو
خايف اعمل له توتال هيب،
ملهاش اي علاقه بالموضوع.
انا كنت عايز اعمل له توتال هيب بس كنت خايف عشان هو ابيليبتيك.
بالظبط. الابيليبسي ده ممكن يخلعه لك لو هو مش كنترول. لو جاله فيت يخلع لك الدنيا
هو
كلها.
جاله فيت، هو مش كنترول، هو جاله الكسر. هو لما جاله فيت وبعد كده جبت له ابيليبتيك نيرس يشوفوا يظبطوا له العلاج وبتاع. استنى يشوف انا.
انما لو هو مش ابيليبتيك، هل انت هتغير البلان بتاعك؟ I don't think so. يعني قصدي حتى لو هو مش ابيليبتيك I don't think so. برضك البلان it is the same.
مش قصدي، اصل هو عنده كل البور بروجنوستيك فاكتور للاستابلر فراكشر. يعني عنده دوم امباكشن، هيد امباكشن، مارجنال امباكشن، ونيكو فيمر كومينيوتد.
I think Ahmed you spent long time putting all the negative kind of predictors just to direct the flow to
برضه ما نفعش.
ايوه لا ما هو
كنت هقول لهم عنده ستروك. راجل جاست
اللي هو راجل بيسحب
دلوقتي باوند وعنده ستروك يا جماعه. فيكسيشن
وخالته ماتت محروقه.
برضه فيكسيشن برضه.
هي بالذات الحاله كمان بتاعت دكتور ايمن الثانيه، حته الفالجاس اوستيوتومي والبيج جاب. وده
انا المفروض يعني كنت عملت برزنتيشن بعد الدكتور ايمن بتاعت حالته الثانيه عشان بقى ما حدش يتكلم عن الحاله بتاعته.
يعني اللي هو ما فيش ناك دلوقتي. واي دونت ثينك اتس فول يونايتد
وانفكتد يا عم.
اي ثينك والامبلانت لوس وانفكتد اند هيز دوينج ويل
اصلا. راجل
انا بقول لك ده ماشي
لا خد السكه ده، خلاص خد السكه.
بالظبط كده، بتفندلنبرج وماشي مع مش هو مفيش نيك اساسا، هو خلاص ما بقتش
مفيش.
هيد لزق في يعني
تعمل له
anyway.
هيب بقى، يجي له انفكشن وتعمل له 2 ستيجز وهيدخل بقى في اوسكار وابدكتور.
ما هو بص انا هقول لك حاجه، الايرا بتاعت تو كونسيرف دي يعني انا عشت اخرها. احنا كان زمان الفراكشن نيك اوف فيمر اللي ما بيحصلهاش يوني كنا بنعمل لهم ماكميري اوسيوتومي، ديسبيسمنت اوسيوتومي.
ايوه.
وشفت الحالات طبعا اللي هي ماشيه بماكميري اوسيوتومي، طبعا قليل منها اللي كان مستريح، لكن هو ما كانش فيه في الوقت ده غير الاوبشنز دي انك انت تعمل كده، والعيانين ماشيين كلهم بيعرجوا وماشيين مش عارف ايه وخلاص، وانت ما فيش اوبشن. ما انت من 30 سنه ما كناش بنعمل توتال هيب ريبليسمنت، انما دلوقتي ان ذا ايرا ان هو التوتال هيب ريبليسمنت از ستاندرد براكتس. طب ليه انا ما ادلوش نورمال هيب يعني، او مش نورمال، نير نورمال هيب فانكشن، ان هو يقدر يمشي ويروح ويجي ويقعد ولو انت خايف عشان هو مانيوال وركر وعشان هم في يعني حد في الفلاحين بيقعدوا على الارض ومش عارف ايه، طب ما تحط له ديوال موبيليتي بيج هيد ويعيش كويس ويقعد على الارض ويقرفص ويعمل اللي هو عاوز يعمله بالتوتال هيب ريبليسمنت.
يعني هو عمليه النيك اوف فيما دي يعني في اليونج ادلت هو عمل عمليه واحده ما نفعتش خلاص، مفيش بقى عمليه تانية، هي واحده بقى خلاص، هي عمل فيكسيشن، لحم حلو، ما لحمش
بص
بقى
بقى
خلاص.
دلوقتي انا عاوز اديكوا فكره عن ايه اللي اتغير في البلد دلوقتي من ناحيه الارثروبلاستي والامبلانتس والكلام ده. بص يا دكتور احمد ودكتور حازم، احنا دلوقتي العيان ما بيشتريش مسمار، كله مجانا.
الله ينور دكتور ايمن ودكتور طارق. انا سمعت
يا عم لا،
الوحده
احنا ما
عامله
عملناش
شغل
حاجه
جامد.
بنظام الدوله.
الحمد لله.
لا الوحده كمان، الوحده بيقولوا يا عبد الله
والله ما شاء الله
ماشي كويس.
احنا بنعمل تقريبا في الاسبوع نيرلي حوالي من 8 ل 10 حالات جوينت ريبليسمنت.
ما شاء الله. ده جميل.
النقطه ان احنا ممكن تو دبل ذات نمبر، بس هي احنا عاوزين مور ثياتر سيشنز.
انت عايز
مور ثياتر سيشنز كمان، لان احنا محكومين بالتايم اوف ثياتر، لان الثياتر ده ويشير مع 3 وحدات، فاحنا بناخد الوقت اللي هو متاح لينا. مع افتتاح وحده الاصابات اعتقد ان هو احنا ممكن تو انكريز، مش كتير قوي بس احنا ممكن تو انكريز من 12 ل 14 في الاسبوع.
وحضرتك كمان بتعملوا حالات كومبلكس، لان الحالات الستريت فورد هتروح على المستشفيات
بالظبط، من ضمنهم حالات ريفيجن، يعني احنا الرقم اللي انا بقوله ده من ضمن ريفيجنز.
صح.
طب والامبلانتس اخبارها ايه يا دكتور؟
الامبلانتس دلوقتي الدوله بتوفر كل الامبلانتس، اي حاجه سواء في توتال هيب، توتال ني، تروما، عين دخل يعمل جمانيل، يعمل ما اعرفش ايه، يعمل
ما شاء
ايه.
الله حاجه
فدي
تيومر بروسيسز.
لا يعني البراندز اللي شغالين بيها ايه مثلا الهيبس والنيز
احنا كنا شغالين
اللي هي كل الناس شغاله بيها، زيمر بتاع ده ليما، بتاع ده السترايكر.
ينفع
يعني
في سترايكر رجعوا تاني ولا مش كانوا قفلوا؟
بس لا ما قفلوش، بس هم سترايكر عندهم مشكله في
الشارع الموحد للنيز بس.
نزلوا النيز ما نزلوش الهيبس، بس هي النيز القديمه بتاعتهم.
وأورسو هاوس دول بتوع ديلما الايطالي
بتوع ليما.
يعني دلوقتي ما في تراياثلون يعني؟ في
لا مش تراياثلون، لا لسه احنا في السكوربيون، خلي بالك.
لسه السكوربيون.
بس
هم في بي اف سي، ما في بي اف سي حلو.
بي اف سي موجوده بس ما دخلتش لغايه دلوقتي في الشارع الموحد، بس في طريقها انها تخش.
الاتش بي
الاتش بي جميله جدا.
بيحبها
جميله.
انا بشتغل بيها جميله، والالات بتاعتها الانسترومنتس بتاعتها حلوه قوي.
امبلانت كويس، بس النكست جين كامبلانت احسن، بس البي اف سي كانسترومنت احسن.
الاتش بي انسترومنتس روعه،
بس النكست جين
بريسايز
احسن في الباتيل.
الباتيلا مور فريندلي بتاعت نيك جين.
نيك جين احسن كتير.
مور
البي اف سي
فريندلي.
هتضطر ان انت تعمل شويه ريسيرش.
والله بص انا انت عارف انا ما بعملش ريسيرفسنج خالص. انما هي البي اف سي انت عاوز بتبقى الاكسنسور ميكانيزم ويل الايند.
يعني قصدي مش يوزر فريندلي، بس ساعات يعني حتى هم المانيفاكتشر هنا لما رحت الكورسز بيقول لك لو هتعمل بي اف سي خلي عندك لو ثريشولد ان انت تعمل باتيلر ريسيرش. عشان هم عارفين ان في عيب بيظهر في الديزاين، انما النكست جين ممتازه مش محتاجه.
تعرف يا احمد انا اشتغلت بالبي اف سي دي كانت ما فيهاش رايت وليفت قبل السيجما.
لا ما لحقتش دي، لا انا ما لحقتش.
قبل السيجما
والله كان الفيمر عادي تحطها عادي.
يعني الرايت ما فيش رايت وليفت
والله.
زمان كانت اللي هي كانت التروكيلا كانت سنترال. تمشي الاثنين.
واشتغلنا ودخلت
انا اشتغلت قبل الايرا بتاعت نيك جين اللي كان فيه لو ما اعرفش حضرتها ايمن ولا لا. لا الاي بي 2. الاي بي 2
طبعا.
انا اشتغلت بالاي بي 2 اللي هي اشتغلت في بليمس بالاي بي 2. وبعد كده لما نزلوا النيك جين يا سلام وجم بقى وعملوا لونش ومش عارف ايه.
هي حلوه جدا النكست جين، بس هي الالات هي اللي وحشه.
الات وحشه.
انا اشتغلت بحاجه اسمها الروتا جلايد.
بتاع بولوزيسكي بولوزايدز.
اول بلاتفورم اتعمل خلاص. ده كان كل التيبيال كات اي بولينج، ما كانش فيه انسترومنت.
ده زي الدكتور ماهر.
لا ده كان مفيش اصلا.
لا انا ما لحقتش.
الالاينمنت بتاعها لا كان خطير.
انا شفت الفانجارد، انا اشتغلت بالفانجارد شويه.
انا ما اشتغلتش بالفانجارد.
يعني بدائيه شويه بس الريزلتس بتاعتها كويسه.
هو بص انا هقول لك حاجه، انا رايي ان هو most of the needs اللي في الماركت الريزلتس ار comparable most of them if they are done properly.
صحيح.
لو هم اتعملوا
بس حضرتك عليها
بالظبط. انت بتتعود على الالات وبتتعود على البروسيسز، بس الريزلتس بتاعتهم if they are done properly اغلبيتهم زي بعض.
يعني بس دواخلها وخوارجها.
يعني مش طبعا الحاجات الجديده بقى الترايسلون اللي ما اشتغلتش بيها.
هي البيرسونا دي فظيعه، انا عملتها في كندا دي حلوه جدا.
انا مش اشتغلتش بيها برضه. بيقول لك هنا لو جابوها هتبقى البروسيس ب 60,000
غاليه جدا.
60,000 طبعا مين هيعمل؟
سنجل راديوس برضك البيرسونا دي سنجل راديوس.
سنجل راديوس والاسيمتريكال تيبيا.
صح.
التيبيا اسيمتريكال والسايزز وحايد. وفي ما تماتش 6 سايزز على التيبيا او 7 سايزز والعكس.
اسيمتريك تيبيا دي بتقلل لك بقى الامبنجمنت اللي بيحصل عند
لا عمرها مش بتفت يا دكتور، لازم بتفت.
عمرها ما بتفت.
ما انت تلبس كده ومفيش بقى فيمر كبيره وتيبيا صغيره
انا بقول لك انت في حالات كتير قوي تبص تلاقي نفسك انت مضطر يبقى في سام اوفر هانج البوسترولاترال شويه. طب هعمل ايه طيب؟ ما هو ربنا خلق اللاترال تيبيال كوندايل مش شبه الميديال تيبيال كوندايل.
لا صح.
خلقت ربنا كده.
خلقت ربنا الاثنين مش شبه بعض. طب انا هعمل ايه طيب؟ وفي بعض العيانين بيشتكوا من بوبليتيس امبنجمنت.
لو كمان لو حد رفيع ولا بتاع بيحسوا يقول لك انا البتاعه دي تحت الجلد.
انا بقول لك انا شفت في حالات انا عاملها مش اقل مثلا من بتاع 3 4 عيانين قعدوا يشتكوا من بوبليتيس امبنجمنت.
او اي تي باند حتى.
هتعمل ايه طيب؟ ما انت يا اما تطلعها انتير يا تطلعها بوستير. لو طلعتها انتير انت بتقلل الروتيشن وما بتبقاش طبعا كويس عشان تراكنج. انما لو انت ظبطت الروتيشن كويس بص تلاقي اوفر هانج بوستير. هعمل ايه طيب؟
والبوليإيثيلين وحايد
كمان في البيرسونا.
في البيرسونا وحايد 1 ملم انكريمنت. فما
فيش
بقى مشكله بقى.
لو جابوا عندنا هنا مش هيبقى وحايد، خلي بالك.
لا هيبقى هو 2 بوليإيثيلين هتختار منهم.
انت بص انت ساعات ساعات تقع في الزنقه في دي وانت تقول ايه دي ما كانتش عاوزه 12 كانت عاوزه 11.
ايوه
بس كده دي
احنا
كانت
هنتكلم
11
فاميلي
تبقى
برضه.
بيرفكت.
ايوه ده انا اشتغلت شويه في مصر يقول لي اللي هو في 2 ستيم، هو ما عندناش غير 2 ستيم دول.
هم لغايه دلوقتي الاثنين موجودين حتى هذه اللحظه.
هو ما عندكش، هم طوال قوي يعني، ما فيش الشورت ستيمز، فهو طويل وما فيش اوفست. يعني اللي انا لقيته التibia ما كانش عندهم الاوفست، فلازم بقى
هو
تظبطه بالظبط.
في اوفست وكل حاجه، بس انت عمرك ما
مش موجود.
بتلاقي المقاسات. يعني
ما
يقول
كانش
لك ايه
موجود
انا عندي
المقاس.
في الاوفست في ال 14 وال 15 بس كده.
ايوه حاجه
طب انت
كده والله.
بقى عيش حياتك.
حاجه كده انت بتقيفه، يا اما بقى لازم بقى تظبط الانتري بوينت بقى انتير خالص جدا عشان تتاكد ان انت التibia مش تاخد اوفست. النكست جين غبيه شويه برضو، LCCK او النكست جين غبيه. التibia لازم ممكن تعملها من غير اوفست، بس في الفيمر بتحتاج اوفست، احتمال كبير تحتاج اوفست.
الفيمر انت احتماليه الاوفست عاليه.
مش بتظبط كويس على الكنال.
انت احتماليه الاوفست عاليه طبعا،
عاليه جدا في الفيمر. فاصل
آه.
النكست جين وما عندهمش بقى، وسايبين اوفست صغير كده مخبيينه،
اللي هو
الستابي.
السيمنتد الصغير ده الستابي.
الستابي ما
ما
بيطلعوش.
هو ده مخبيينه، لان انا كنت دايما اقول لهم
مخبيين
بصوا.
الحبايب يا دكتور طارق.
ايوه اقول لهم خلوهولي. اصل انت في حالات
يقول لي لا احنا طالعين شايلين الحبايب بس، استنى يا عم.
اصل ساعات انت بتتزنق، انت بتبقى عاوز خلاص، انت اتزنقت وعاوزه. في عندك اكسترا ارتيكولار ديفورميتي.
ايوه
التيبيا فيها فالجس ولا ما اعرفش فيها ايه، ما انا مش هعرف احط لونج ستيم.
هم عندهم 2 بس شايلينهم في المخزن،
واحد 12 واحد 15.
واحد دكتور ايمن والتاني دكتور طارق.
لا انا ما بيشيلوليش حاجات من دي والله.
يا دكتور ايمن ده انت المدير.
والله بص الحمد لله.
بص انت الحل الاخر انك تجيب معاك منشار حدادي وتيجي حاطط الستيم وقصه وعامل له سيمنتنج. خلاص تيجي جاي ناشر الستيم وعامل له سيمنتنج.
انا في التibia اقول لهم ايه، انا عاوز عشان احطه من غير اوفست، انا عاوز the thickest smallest ستيب في التibia. بس طبعا الفيمر لا بيحتاج طبعا اوفست.
الفيمر صعب. النكست جين خصوصا.
احنا سعداء جدا يا جماعه، وان شاء الله
ده احنا والله اللي اسعد.
تقولنا بالسلامه ان شاء الله كده نتجمع على ده.
والله القعده 10 دقايق دول بالميتنج كله بصراحه.
والله
ربنا يخليك.
احنا لازم نعمله احنا زوم ميتنج
لازم
كده
نعمل
افري ناو
meeting
نقعد نتكلم بس كده.
والله يا ريت.
سوشيال
على فكره
ميتنج.
ممكن نعمل كده حقيقي.
طب وليه ما نعملش كده؟
نعمل كده مع الناس بتوعنا في المانيا والناس اللي في انجلترا ونظبط كده.
مش لازم حاجه يعني، مش لازم حاجه علميه يعني، او حاجه
علميه مين يابا؟
انا بقول لهم مش لازم حاجه، مش لازم نتقابل في حاجه علميه يعني، ما نتقابل سوشيال ميتنج.
ما انا بقول لك سوشيال نقعد نتكلم كده، نقعد نتكلم
مره كل اسبوع ولا 2 ولا مره فاضيين نبعت.
واللي عاوز يسال في حاجه علميه يسال برضك. الواحد بيتشينج معلومات واكسبيرينس. لا من غير استئذان على طول. والله يا جماعه احنا سعدنا بيكم النهارده، وان شاء الله نلتقي على خير فيزيكالي.
يا رب.
انتوا وحشتونا يعني
باذن الله.
يا ريت والله يا رب ان شاء الله.
نشوفكم على خير.
شكرا يعني.
تصبحوا على خير بقى.
تصبحوا على خير دكتور ايمن.
يلا سلموا على اللي عندكم.
ان شاء الله.
Thank you very much.
اشوفكم على خير.
يلا السلام عليكم.